Hi. How are you doing? Rennie, how are you doing? Push it, turn, wait, let's see. Anita, welcome. How are you guys doing? Oh, George, hi, welcome. Ferdinand, Mindful Medic, welcome. How are you doing? Kelly, Miss Brooklyn, ready, boo? Welcome. Blessings. Jacqueline, good night, Rennie. How are you? How was your day off? How was election day? Well, that was yesterday. I am doing good. Yeah, I'm doing good. It wasn't a bad day, so okay, nice. Is this thing on? I don't even know. It wasn't a bad day. Okay. So what you did today? Were you out counting ballots too? Or them actually done count everything already? You ready for questions tonight? Unparalleled. Welcome, Jamarock. Welcome, Jacqueline Lewis. All right, I think these folks are passing through. I'm gonna try to remember to go ahead and put up on the, you know, the calendar that the live is gonna be on Thursdays or whatever, you know, that way. Yeah, so I'm gonna try to do that. Okay, Unparalleled Paradise. I'm gonna try to do that so I can, you know, so other persons can get a chance to join in. Bascos 5. Nobody's Bay. Welcome, welcome. How are you doing again? Roxy Fighter. Yeah, no, Rennie. Just messing around with you. Just messing around with you. Alright. Noel Isaacs, welcome. Young Tass. Alright, so you guys ready to... Hey Marvin, Wagwan. You guys ready to do some questions tonight? Let me charge it. Oh, you're working tomorrow? Okay. I suppose you're working day shift tomorrow, right? Seeing that you're off today? Well, at least that's what I'm thinking. Okay, good Marvin, good. Okay. Alright, so we're gonna do some questions again tonight. Let's see if more persons gonna be coming on. Oh, you were on today as well. Oh, just a girl. Okay, okay, nice. Well, my side of the party did one, but time come, yeah. Okay, yeah, green girl. Okay, all right. I understand. Yeah. But you know, let's see what they're gonna be doing. You know, that's all we have to do. We just have to see what they're gonna be doing, and then from there. But I think he deserves a second chance. That's all. You know, that's all I can say. Not into politics, but you know, I think he deserves another chance. I think he was doing a good job. So kudos to him on his third run. Yeah. So. Alrighty, well, I guess more people will come on eventually when we start the questions. So if you're ready to do that, 3 terms, yeah. So definitely that is something, you know. Just hoping that, as I was saying earlier today, just hoping that the healthcare is something that is going to be priority for him and his team. Focusing on that would be very, very important. So we'll see how that goes. All right. Or remember to like up the live and remember to share. Did I share it? I think I did share. Yeah, let me go ahead and share up the live. All right. So share up the live and all those things. Get some folks over here. Double tap up your screen. Get the video, you know, send out to some other folks. And then from there, we'll see. All right. Roxy's the fighter. Welcome, welcome, welcome. Mr. CC 109. All right then. Well, we'll just start having fun. What do you say about that? All right. So I have a mixture of questions. So I think what I'm gonna do, you guys can tell me what area you want me to like prepare some questions for. Like, so for example, respiratory, cardiac, you know, renal, the different systems, how you want it, and we can always go ahead and do that. Can try probably like say 25 questions of each, and then from there. But if you feel as though cardiac or cardiovascular is not your thing, we can always go ahead and do some questions, look at the rationale. I remember this is more of like, you know, just trying to study mental health and maternity. Okay. And then from there, at least we can discuss a few. There was a young lady the other night. I think probably she is in maternity, because she was helping us out real good on some of the questions. Yeah, I think her name was like Missy something. I don't remember Missy who, but definitely at least other persons can join in and help. So mental health, maternity. I don't think you have like much of those questions though coming on the exam, you know, because those are specialist area. But it's okay to study those, but I don't think the bulk of them is gonna be from that area. So majority of the exam questions are gonna be focused around, when are you gonna be having your exam, just a girl? Or when you plan to do your exam, like what time period we're looking at? Ariel Nurse, welcome. I'm trying to look at the outline for the NCLEX questions section. And let me tell you, because you have clinical, you know, like a certain percentage. I think I go through that the other day. So management is gonna be 15 to 21, safety and infection 10 to 16, 6 to 12% for health promotion, 6 to 12 for psychosocial, reduction of risk potential pharmacology, 12 to 18 basic care management. Okay, yeah, all right, but we can actually do that. Oh no, Jack Jeans, I'm already married, sorry. All right, just not so sure. Okay. But thank you for passing through. All right. All right, so we can do that. Focus on a lot of clinical questions, look at the rationales and everything, and then from there. All right, so let's start off the show tonight with the first set of questions. All right, and then as usual, A, B, C, D. Riri, Simone, welcome again. All right, welcome. So we're gonna do A, B, C, D, and then we kind of go through, and from there we decide, you know, on the answer. So whichever answer you feel as though is correct, you just put it down there. Even if you don't have the correct answer, just guess something. All right, you're in the exam and you're the nurse that is with the patient at the bedside, so you're just gonna answer and see if you save the patient life. How does that sound? Welcome on YT here. Oh, and if you haven't followed us yet, you can follow me on TikTok at ThinkNursing, and it's the same handle on YT, which is YouTube. Follow me over there for the full length of the live, just in case you miss it. There are questions that we did before. You can always go over to YT and get them, and other things regarding nursing. So just a little bit about my background. I'm a nurse, emergency room nurse. I'm a nurse practitioner. I do host call. I'm also an international nurse from Jamaica. So I talk a lot about my transitional journey and just about a bag of things, you know. Go over there and check out the channel, subscribe, and ask any questions. Feel free to reach out to me via text, or you can inbox me. All right. All righty. Let's get into the meat of the matter. The first question. Hi, Marcia. A nurse is caring for a client with COPD on 2 liters of oxygen via nasal cannula. The client's oxygen saturation is 88%. What is the best action? A, increase oxygen to 6 liters per minute. B, encourage pursed lip breathing. C, place the client in a supine position. D, notify the provider immediately. So the patient is on 2 liters. The patient is also a COPD. What is the best action if you notice that the oxygen saturation is at 88%? A, increase the oxygen, encourage pursed lip breathing, place the patient in a supine position, and notify the provider. B, okay, do we have anybody else? D, okay. Hi, Kai, thank you so much for tuning in over here. Oh, you're saying D, okay. All right, so we'll try to take at least 3 answers so we can actually cover a lot more questions and answer. All right, so whoever says B is correct, encourage pursed lip breathing. And why is B gonna be correct? Remember, this patient is a COPD, all right? So what's the range you're looking for with oxygen saturation for a patient with COPD? 88% is pretty good, all right? And plus the patient is on 2 liters, so you just need to encourage them to practice a little bit more, you know, lip breathing. Increasing the oxygen is not going to be one of the best answer for that patient, all right? Because remember, COPDs, usually their oxygen level runs low. All right, place the client in a supine position is going to make that even worse in terms of their breathing. Notify the provider immediately. Now, once you can always notify the provider, but once the oxygen level is there, there's no need to rush to tell the doctor that, you know, the COPD or oxygen is at 88%. All right. So 88% is acceptable for COPD. Pursed lip breathing improves oxygenation without suppressing hypoxic drive. All right. Which finding in a client with DKA or diabetic ketoacidosis requires immediate intervention? All right, and we know that DKA or diabetes ketoacidosis is a life-threatening condition, right? It's a life-threatening emergency. So which finding requires immediate intervention? Is it blood glucose of 350 milligrams? Is it potassium that is 2.9 milliequivalent per liters? A serum bicarbonate of 18 milliequivalent per liters? Or D, a pH of 7.30? So the patient is in DKA, all right, and you have these lab values. Which of them requires immediate intervention? A blood glucose of 350, potassium of 2.9, bicarbonate of 18, or a pH of 7.3? A, B, C, D. All right, so Kai says A, which is blood glucose of 350. Do we have anybody else? Paulette says A. Do we have anybody else? So blood glucose of 350, a potassium of 2.9, a bicarbonate of 18, and pH of 7.3. All right, this patient is in DKA. So we have everybody saying A, a glucose of 350. All right, so what about the potassium of 2.9? What's the normal, you know? I know the glucose is abnormal, but between the glucose of 350 and a potassium of 2.9, which one would you say is priority? Are we going to say the potassium or the glucose? Because remember, the potassium, if you're hypokalemic, you're going to have arrhythmias because of that. So you definitely want to go ahead and address that one first. All right. And then if the patient is in DKA, you're going to be administering insulin, and you want to make sure you correct your potassium before administering that insulin, because you don't want to further deplete that potassium level. Yes, definitely. So the normal for your potassium is going to be anywhere between 3.5 to 5. All right. If it is too low, you have to replace it before you start your insulin. All right. So the potassium of 2.9 is going to be the one that requires, immediate intervention. All right. So severe hypokalemia is a life-threatening condition, and it must be corrected first before. So whenever you're doing your DKA, or you have a patient that is, diabetic, and you're going to be doing your insulin, always eyeball your lab values. Look at your electrolytes, your potassium, to make sure that is good before you actually give your insulin. All right. After thyroidectomy, which equipment must be at the bedside? So you had a patient that just went in, took out their thyroid gland. Which equipment you definitely need to have at your bedside? Is it the cardiac monitor, a suction equipment, tracheostomy tube or tray, incentive spirometer? Which one would you definitely have at your bedside? A, cardiac monitor, B, suction equipment, tracheostomy tray, and an incentive spirometer. C. Okay, that's a tracheostomy tray. All right. Do we have anybody else? Do you want to have a cardiac monitor, suction equipment, tracheostomy tray, or incentive spirometer? One person on YT. All right. So just the girl says C, which is a tracheostomy tray. So definitely you want to have that because, you know, because of the risk for the swelling. You don't want to have any form of occlusion taking place there. So you want to definitely have your tracheostomy tray there in the event that you have any obstruction from that swelling. All right. Nothing is wrong with having your cardiac monitor. We have it at everybody bedside in America here. So, you know, that is pretty common. Your suction equipment, definitely you want to have that. Incentive spirometer, no. What we're doing with that for now. All right, so definitely your tracheostomy tray. Airway obstruction from swelling is a major risk, and so having your trach set must be readily available. So in the event that something happens, you want to go ahead and just get an airway going. All right. A client taking warfarin as an INR of 5.2 and minor gum bleeding. What should the nurse do first? All right. So you have a patient that is on warfarin, and the INR is 5.2. The patient is also having a little bit of a bleeding, minor gum bleeding. What should the nurse do first? Thank you for the follow. All right. Is it going to be A, give vitamin K, B, hold the dose and notify the provider, C, continue the medication, or D, administer protamine sulfate? Sorry about that. All right, so the patient is on warfarin, INR 5.2, and the patient is having minor gum bleeding. What should the nurse do first? Give the vitamin K, hold the dose and notify the provider, C, continue the medication, or D, administer protamine sulfate? A, okay, so give vitamin K. Do we have anybody on YT? Hi, Renee. Welcome, welcome. At least one more answer. So, all right. So, if you have the INR that is already at 5.2, that is a subtherapeutic level already. So, you don't want to go ahead and give the warfarin. All right, because you'll be further causing thinning of the blood, worsening the bleeding. So you want to hold off on that and let the provider know. All right, so B is going to be the most appropriate answer, which is hold the dose and notify the provider. Continuing the medication is going to further, as I say, thin the blood. All right, and worsen the situation in terms of the bleeding. Administer protamine sulfate. Depending on, you know, if it is a case where the bleeding is like prolonged, then you can always go ahead and administer your protamine sulfate to help with correcting that. All right. So the INR is subtherapeutic. Hold and notify for dose adjustment. All right. Which statement shows correct understanding of furosemide teaching? And we know that furosemide is the same thing as Lasix. It's a water. We normally say water pill. All right, so which statement shows understanding of furosemide? Hi, Metro. All right, no problem. Go ahead and follow. So just the girl is saying, why not A? Give vitamin K. So nothing is wrong with at that, it's not like, you know, with vitamin K, you don't want to go ahead and just give it. It's minor gum bleeding. So as I was saying, you can always go ahead and hold off a little bit. I don't think it's that bad in terms of the bleeding for you to start your vitamin K. All right, so that's just my answer on that. All right. So if it's a case where, you know, you realize that it's so bad, then definitely you can always consider that. All right. But what would you do first is to notify the provider, and then the provider is going to say, okay, then we're going to do this or we're going to do that. All right. So which statement shows understanding of the furosemide, which is a water pill? Minor is the key word. Yes, Sky. All right. So which statement shows understanding of furosemide treatment or teaching? If the patient says to you, I should limit foods high in potassium, I'll eat bananas and oranges daily, I can skip doses if my blood pressure is normal, this drug will not cause me to urinate more. So if the patient says one of these to you, which of these says that the patient does understand the effects or, you know, of the furosemide? I should limit foods high in potassium. I'll eat bananas and oranges daily, which is B. C, I can skip doses if my blood pressure is normal. And D, this drug will not cause me to urinate. Eat food in potassium. Okay, so Kai says B. Do we have anybody else who has another answer? Kevin, welcome, welcome. And we know what class of drug is furosemide. So once you know what furosemide, so bananas and oranges, okay. So once you know what furosemide does, then you can always go ahead and answer the question. So furosemide is a loop diuretic. And a lot of times you tend to be passing out, you know, your sodium, your potassium. So you want to ensure that you're replacing that. All right, so you're losing your potassium. So you want to make sure you're encouraging the patient to eat anything that has high amount of potassium in it. All right, definitely potassium wasting. So I'll eat bananas and oranges daily to make sure that, you know, they don't become hypokalemic from the furosemide. So sometimes you might see some providers go ahead and if the patient is on it for long term, then they will go ahead and do like, you know, a low dose of potassium tablet to help with that. Because how often you have people eating bananas, you know, or potatoes that are high in potassium. So in order to prevent or, you know, the risk of hypokalemia, then you just go ahead and give them their 1 liter tablet to take daily. All right. Yes. So I can skip doses if my blood pressure is normal. No. This drug will not cause me to urinate. It definitely causes you to pee a lot. So a lot of patients tend to not want to take it, or they're very non-compliant. I should limit foods high in potassium. No, it's the other way. You want to consume high potassium food. All right. Which task can be safely delegated to your unassisted personnel? What's that again? The UAP. Unlicensed assisted personnel. All right. Which task can be safely delegated to that person? Is it A, teaching incentive spirometer use? B, assessing incision for infection? C, obtaining vital signs for a stable post-op client? And D, evaluating pain control. So which task can you safely delegate to your UAPs? So Kai says C. Someone here says C. 660. Welcome. All right. So both answers are correct there. Obtaining vital signs on a stable post-op client. Teaching, anything that has to do with teaching, initial teaching, assessment, that is going to be the duty of or the responsibility for your registered nurses. All right. So just a girl, repeat the question. Which task can be safely delegated to your unlicensed assisted personnel? So is it teaching incentive spirometer use, assessing incision for infection, obtaining vital signs for stable post-op client, or evaluating pain control? Nikki Knight, welcome, welcome. Why you always watch my forehead? Huh? C? Okay, yes. So C is the answer. Obtaining the vital signs for a stable post-op patient. All right. So the word in the sentence there is the stable. All right. So out of the 4 patients here, the task that you would recommend to that or delegate would have been that. Anything that has to do with teaching, initial teaching, assessment, evaluating, has to be the responsibility of the nurse. You can always have like your LPNs do re-evaluation, things like those. They can like you already did the initial education with the patient. They can always go ahead and reinforce, like education with them. But they're not the one that is going to be primarily doing or initially doing that education teaching moment with the patient. All right. So stable routine care task may be delegated. All right. A client with clozapine reports sore throat and a fever. Which is the nurse's priority action? Let me look up that one. Is it give acetaminophen, hold the drug and obtain white blood cell ANC, encourage fluids, or continue medication as prescribed? So a client taking clozapine reports sore throat and fever. Which is the nurse's priority action here? Give acetaminophen, hold the drug and obtain a white blood cell count, encourage the fluids, or continue medication as prescribed. And if you're not so sure what clozapine is, it is a atypical antipsychotic medication that is used to treat severe or treatment-resistant schizophrenia and to reduce suicidal behavior in patients with schizophrenia or schizoaffective disorder. It is not a first-line treatment due to its potentially serious side effects, including the risk for life-threatening blood condition called granulocytosis. All right, so I don't know how many persons knew that one, but the answer is B. Kai says B. Nice. Last resort. Yes. Yeah, I'm not familiar with it. All right. So client taking clozapine reports sore throat and a fever, which is a nurse's priority action. The answer is going to be B. All right. Hold the drug and obtain your white blood cell count because, as I say, it causes agranulocytosis. All right. So you want to check your lab values. Nothing is wrong with eventually giving your acetaminophen or Tylenol because they have a fever to bring that down. Encouraging fluids because, when you have a fever, you lose fluids as well. So you want to make sure you push a lot of fluids. And continue medication as prescribed is that's not what you're going to be doing. All right. Because if it is causing problems with the white blood cell count, definitely, or if it can cause that, you want to make sure that you're holding that medication and see if it is the medication that is really doing that before you continue with it. All right. So agranulocytosis is a dangerous side effect. So definitely you want to hold the drug and obtain that white blood cell count. All right. Definitely user 6602. Rule out that. All right. Go ahead and top up the live. Let's go to 1,000 live. Let me drink some water in the meantime. And thank you so much, everyone, for tuning in. All right. Thank you so much for tuning in. And if you haven't followed us yet, go ahead and follow, subscribe to my YT page, and do all the wonderful things that you normally do on a regular channel and a regular page. Marvia, welcome. All right. So continuous bubbling is seen in a chest tube water seal chamber. What does that indicate? Is it a normal finding? Is it an obstruction in the tubing? Is it an air leak or fluid overload? So you have a patient that has a chest tube and you see continuous bubbling in the water seal drainage. What does that indicate? Marvia says a leak. C, leak. Kyle says leak. Okay, nice. Just a girl says a leak. Yes, it's an air leak. So you don't want to have continuous bubbling. If you see continuous bubbling, definitely go ahead and get that checked out. All right, it's not a normal finding. Sometimes you'll see little bubbles, but if it is continuous, all right. Intermittent bubbles, you might see 1 and 2, but the continuous one is the problem. Obstruction in the tubing, fluid overload, no. It's the one that is, you know, the air leak usually gives you the continuous bubble. If you have obstruction in the tubing, sometimes you can be looking out for your tension. You understand? Look up by the neck and all of those things, the blood pressure and everything, to make sure that the patient are probably not having like a tension pneumothorax. A client with Addison's disease is vomiting and cannot take oral medications. The nurse should suspect A, hypertensive crisis, B, Addisonian crisis, C, myxedema, coma, or D, SIADH. So a client with Addison's disease is vomiting and cannot take their oral medication. The nurse should suspect crisis B. Nice. Okay. Do we have anybody else? Is it hypertensive crisis, Addisonian crisis, myxedema, coma, or SIADH? Marvia says B. Nice. Just a girl says B. Nice. Okay. Let's just kind of look at these for persons who are not familiar with the answer. So the answer is actually B. All right. The Addisonian crisis. So inability to take steroids during stress triggers crisis. All right. So the SIADH is your syndrome of inappropriate antidiuretic hormone secretion, and it is a condition which usually you have high levels of the hormone causing the body to retain fluid. In this condition, the body retains water instead of excreting it normally in the urine. And myxedema, coma, so we're gonna just look at that one. That one's a rare life-threatening endocrine emergency that occurs when the thyroid hormone regulation is disrupted, and it is most severe form of the hypothyroidism and is often fatal even with treatment. And you have your hypertensive crisis. All right, severely elevated blood pressure is referred to as hypertensive crisis due to a high risk of complications. People with blood pressure in this range may have no symptoms but are more likely to report headaches and dizziness than the general population. And which one was the other one again? Oh, and then let's look at the Addisonian. And we already know that one. And then the Addisonian crisis, adrenal crisis, also known as the Addisonian, is a life-threatening condition that occurs when the adrenal glands don't produce enough cortisol, glucocorticoid hormone. All right. So whenever the client with Addison's disease is vomiting and cannot take the medication, the oral medication, there is Addisonian crisis, and that's because you have the inability to take steroids during the crisis. All right. So which client should the nurse see first? Thyroid storm. Okay. Which client should the nurse see first? A 40-year-old with a migraine, a 22-year-old with fractured arm, a 56-year-old with chest pain and diaphoresis, a 68-year-old awaiting discharge teaching. So which of the patient would you go to see first? Someone with a migraine that is 40 years old, 22-year-old with a fractured arm, 56-year-old with chest pain and diaphoresis, and 68-year-old awaiting discharge. Chest pain. Okay, C, chest pain, chest pain. Noel, thank you. No problem, Noel. Not a problem. Thank you so much for tuning in. All right. So C is the answer, the chest pain and the diaphoretic patient. Disciple of God, yes. All right. So remember, you're thinking about all of your emergencies, your life-threatening emergencies. So anytime you hear about chest pain, diaphoresis, you know, the combination, you want to think about your MI, your myocardial infarction. So you always want to run to those patients first to preserve, you know, or prevent any form of like ischemia or worsening ischemia. So definitely your chest pain is going to be priority. Then if, you know, they ask for the second one, you have a 68-year-old awaiting discharge, that patient is always going to be the last. All right. So you'll be running around taking care of the patients, and then eventually you'll go and discharge, because that one is pretty much stable and ready to go. All right. The 22-year-old with a fractured arm, definitely you probably go and see that one. The 40-year-old with a migraine is another one that you will, you know, definitely see. So if the patient probably had the, like, you know, the vomiting, the diaphoresis and everything with the headache, you know, definitely depending on how bad the fractured arm is, if they're crying out, you know, then you can always make it you can determine who you're going to be seeing. Stable man that, yes. Which teaching point is correct for nitroglycerin? All right, and we know that nitroglycerin is a vasodilator. All right, so once you know that, then you'll try to answer the question. Take it on an empty stomach. B, sit down before taking it. C, it will never cause a headache. D, you can take unlimited doses. So which teaching point is correct for a patient that is on nitroglycerin? Is it taking it on an empty stomach, sit down before taking it will never cause a headache, or you can take unlimited doses? So B, Marva says B. Okay, Just a Girl says B. Definitely the answer is going to be B, this disciple of God. Yes, sit down before taking it, because we know that with the vasodilators, you're thinking about your hypertension, your dizziness. So you definitely want to go ahead and prep the patient. Let the patient know that once you take it, it's going to open up those vessels, and then the blood pressure is going to drop. You're going to feel dizzy. You might have your headache as well. All right, so taking it on an empty stomach, you know, we always medicate, you know, our patients, whether or not belly full or empty, and we still get results just the same. So that wouldn't be like a priority, you know. I don't think it's, most of the time you want them to have something in because of the GI effect. You want to prevent some of those GI effects. So taking it on an empty stomach, you know, it will never cause a headache. Definitely it's going to cause a headache. A lot of patients will tell you, so you can always just tell them to take some Tylenol in the meantime with it to prevent that headache. All right, and you can take unlimited doses. Do we know how many doses we're supposed to be taking for your nitroglycerin? What is the recommended dose, the amount of time? The 3. Okay, nice. Yeah, so you do 3, and then from there you can always reevaluate. Orthostatic hypertension or hypotension. All right, so definitely you want to go ahead and encourage them to take the 3. A lot of times we tell them at home to take only 2. You understand? Because you don't want them to be there taking these 3 tablets and then the pass out. The blood pressure drops so low, and then the pass out. So you definitely want to go ahead and let them know after the second one, if you're still having the chest pain, make sure you call the ambulance. You understand? If unresolved, go to the doctor. Definitely. All right, so risk for dizziness, hypotension, headaches are very common with your nitroglycerin. All right. After posterior hip replacement, which activity must the client avoid? So is it crossing the legs, using the walker, lying supine with a pillow, performing ankle pumps? So after posterior hip replacement, which activity must the client avoid? Is it crossing the legs, using a walker, lying supine with a pillow, or performing ankle pumps? So crossing the legs, definitely, because what is gonna happen when you cross the leg? You just do a hip replacement, and you go take your leg and cross it. What's gonna happen? You're gonna dislocate it, you know. Using a walker, definitely will encourage them to go ahead and use a walker to help with balance. Yes, you're gonna dislodge it. Lying supine with a pillow, performing ankle pumps. What is ankle pumps? I don't even know what is ankle pump. You understand? But definitely you don't want to cross the legs, because that is going to cause dislocation. And sometimes even if you don't know, even if you don't know, just think about certain things and look at the answers that you have and try to just think about it. If I tell the patient to cross the leg, if it means that you have to cross your leg as well in the exam to answer the question, do it. You understand? And then you will determine whether or not, if I tell a patient who had just done a surgery on the leg to cross them leg? Is it going to keep that, you know, hip in place? So things like that, just try and put yourself in the position of the patient and look at the answers and see if it really makes sense. All right. So definitely crossing your legs is going to putting you at risk for hip dislocation. All right. During sickle cell crisis, the nurse's first action is to A, apply ice packs, B, start an IV fluids, C, restrict fluids or give iron supplements. So a patient that comes in and they're like, you know, having so much pain, and the patient tells you that I'm a sickler, or you know that the patient is a sickle cell patient. What is the first thing you're going to be doing? Are you going to be applying ice packs, starting the IV fluids, restricting fluids, or give iron supplements? So IV fluids, okay, nice. Do we have anybody else? All right, so D, give iron supplements. Seriously, Marvia? Huh? Your first wrong answer. You'd give iron supplements. So during the sickle cell crisis, the nurse's first action is to apply ice packs, start IV fluids, restrict fluids, or give iron supplement. Oh, that's an error. Oh, you mean B? Okay. All right, so definitely you'd go ahead and do the IV. Start your IV and start your fluids. All right, you always want to go ahead and push a lot of fluids with these patients, because remember, with sickle cell patients or sickle cell disease itself, how the cell is actually shaped, there's a high chance of them, like, you know, attaching like this and causing occlusion and making, you know, the patient go into crisis. So definitely you want to go ahead and get that fluid going to help with loosening up those cells there. So you start your IV fluids, and from there you can go ahead with your pain management. And what is the drug of choice a lot of doctors tend to use, or what is the drug of choice for your sickle cell patients? And oh, we never go through the first one. Would you want to go ahead and do ice packs? Would you want to go ahead and apply ice packs to these patients? Petidine, pethidine, aspirin. Pethidine? No, I think we did it the other day. I don't think they have I don't think they have it as pethidine. Meropidine, blood thinners, no. So your NSAIDs are pretty good. Aspirin, your NSAIDs are pretty good for them. Some persons do use hydroxyurea. A lot of patients tend to use that and have good results. But pethidine, some doctors will go ahead and do, you know, because the patient is having pain, and sometimes you just need to give them the little pain medication and they're okay. All right, so like your some persons will give the meropidine, or the same thing as the pethidine, and some persons will give your what's that drug I'm looking at in those little syringe again? Goodness gracious. Yeah, but your NSAIDs are pretty good for them. All right, but the most important thing is making sure that you're giving a lot of fluids. And if they start having, like, you know, chest pain, you want to make sure you go ahead and evaluate the patient for ACS, acute chest syndrome. All right, in as much as, you know, a lot of times we might have our patients coming in and they're saying, yeah, I'm having chest pain. You don't want to overlook your sickle cell patients who are having chest pain, because, you know, they might be having a medical emergency that needs, you know, immediate attention. So definitely go ahead and do your fluids and do your full workup for your cardiac, you know, complete. If they're having chest pain as well with their sickle cell, just make sure you go ahead and address that. All right. So hydration decreases sickling. Pain meds are also priority. Oh, let me, what's that called again? That medication, I'm looking at it. I can't remember it. What medication we commonly use in the hospital? I soon tell you. We'll come back to that one. But restricting fluids, you don't want to restrict fluids for these patients. You want to make sure you're encouraging them to stay hydrated. All right, and giving iron supplements. Yeah, eventually they, you know, more than likely they would have been on iron supplements. But if they come in with crisis, you're not gonna, you know, go ahead with your iron supplements at that time. unless their levels are very, very low. All right, Versed. No, I've never seen that one yet, but I'm not so sure about the Versed. I'm not so sure about the Versed. All right. So which new stoma finding is concerning? So you have a patient that has a stoma. All right. Which finding is most concerning for you? If it is pink and moist, if it is red and slightly swollen, dusky or black, or bleeding, mild bleeding when touched. So you have a patient that has a new stoma. Which finding is most concerning? So if you look at the stoma and you realize that it's pink and moist, red and slightly swollen, dusky and black, mild bleeding when touched. So Kai says C, Disciple of God says C, Marvia C, User 66 says C. Definitely dusky and black. All right, because you're thinking about what? Cupids, welcome, welcome. You're thinking about ischemia, no blood flow there. So you definitely want to look at that and address it immediately. All right. It's more circulation, infection. Yeah, circulation mostly. All right. So you definitely want to address that. So pink and moist would be more for circulation as well. Red, slightly swollen. All of those you're going to be expected to see on a new stoma. All right. You might have the mild bleeding, the red and slightly swollen, pink and moist, but the dusky or black is more of like necrosis, ischemia taking place. So you want to go ahead and definitely address that. All right. Early signs of digoxin toxicity is, so you have a patient that is on digoxin. How are you going to know that they've taken too much digoxin in? Is it bradycardia, nausea and anorexia, yellow halos around vision, or palpitations? So you have a patient that is on digoxin. How will you know that they're having digoxin toxicity? Kai says C. Just a Girl says C. Yellow halos around the vision. C. User 66. Halos. Okay. So the answer is actually B. All right. So the early sign, the halos is going to be the late sign. All right. The late signs of digoxin toxicity. So the nausea and anorexia, usually the patient starts getting very nauseous, and as you know, moderate, severe, then the ALO is going to be like, you know, your late sign. So definitely the GI upset is usually the first thing you'll see. All right. Palpitations. Yeah, the patient is going to have palpitations, but it doesn't mean that is related to the digoxin itself. All right. And the bradycardia, the effects of bradycardia is to cause, not the effects of bradycardia, the effects of digoxin is to cause a slow heart rhythm. So definitely you'll have, you know, the bradycardia there. But the early sign is going to be your nausea and your anorexia. And your GI upset is basically what we're looking at for the earlier phase of that. And then the latter phase, you'll tend to have like your visual changes. So your halos around the light and all, or around the eyes and all. All right, so definitely look at that. All right. So which condition requires droplet precautions? Is it tuberculosis, varicella, influenza, or MRSA wound infection? Please. Oh yes, please tap up the screen, folks. Go ahead and tap up your screen. Thank you, Marvia. Flu. Okay, flu. Marvia says flu. Kai says flu. Nice. Okay. Do we have anybody else answering? So droplet precautions. Tuberculosis would be what? Money gun. Thank you so much, user 660. Sorry, I didn't see it. Sorry. Or probably I saw it. I never really even, you know, recognized what it was. So which condition requires droplet precautions? Tuberculosis, varicella, influenza, or MRSA wound infection. So initially I know persons were saying for the droplet, the flu, which is correct. All right, influenza is the one for the droplet. Airborne is for tuberculosis. Varicella is airborne as well. And then the MRSA wound infection would have been like contact. All right, but when in doubt and you have anything that is, when in doubt, just kind of, you know, go full on. Nobody not complaining, just protect yourself. All right. For the droplet, hi Shells. For the droplet, so for the droplet precaution, the answer would have been the influenza, flu. Because remember, when you cough, when you sneeze, all of those droplets, definitely want to go ahead and protect yourself. All right, so you put on your face mask, you put on your eyewear just the same. Oh, yeah. But then for tuberculosis, usually you'll put them in the negative pressure room and you want to go ahead with your airborne precaution. Hi, Jessie. Welcome, welcome. I'm good. You? Okay. All right. And the MRSA wound infection, you do your regular contact precautions. Yes, your N95. So your N95 for your TB. All right. Thank you. So the flu spreads by droplets. So definitely that's the one you'll be using. All right. So a burn client has urine output of 15 mils per hour at 8-hour post injury. What should the nurse do? So a burn client has urine output of 15 mils per hour at 8-hour post injury. What should the nurse do? Is 15 mils adequate per hour for a patient in terms of urine output? No, okay, no. So what is the recommended? 30. Definitely 30 is the recommended. You always want to have 30 mils per hour for the urine output for your patients. That is what you're aiming for, too much within the hour. Okay, so if you have less than that, you definitely have to contact your provider. And in the meantime, as long as the patient is not, having a ton of crackles, sound like the patient is drowning, you can always go ahead and start a little bit of a fluid to help with that. Because with the burn patient, they're losing a lot of fluids. So you want to go ahead and make sure, you're not putting that patient in any form of kidney, acute kidney injury. All right. Sometimes patients can develop like rhabdo because of that as well. So you want to make sure you're giving a lot of fluids to prevent any form of kidney injury. So if the patient has a urine output of 15 mils per hour at 8-hour post-injury, what should the nurse do? A, document as expected. B, increase the fluids per protocol. C, give diuretics. Or D, insert a Foley catheter. So definitely, as you guys said, we said that we'll go ahead and let the doctor know. So basically increase the fluids per protocol. So if the patient is on the fluids, increase it per protocol. All right. Give diuretics, definitely not. All right. If the patient is on any form, you make sure you stop that. You understand? Because you don't want to be pulling too much fluids. And then insert a Foley catheter. Eventually, you definitely would want to have adequate intake and output. So you would want a Foley catheter. But not all the time, because if the patient has 30, depending on where the burn is, and if the patient is able to, pee in the container, you're able to measure it, then you go with that. You understand? But if it's going to cause a problem where you're not able to adequately, do your intake and output because the patient is not able to provide that urine sample, then you might have to go ahead and introduce your catheter. But you always want to try to limit, introduction of anything like your catheters, because that's another risk for infection. All right, so if the patient is able to pee, you put in your external catheter. You put your external catheter. You can collect your urine for your male if they can use the urinal and give it that urine sample without having too much pain, or depending on where the burn is, then definitely you take that. If it's otherwise, you go ahead and insert. All right. But for this patient, the thing that you want to address is the urine output. So you want to go ahead and increase that fluid per protocol so you can start getting that clear urine as well as the amount of urine that you're supposed to be getting. Our lactated ringers, definitely Marvia. So low output is equivalent to inadequate perfusion, and so you want to go ahead and titrate your fluids. Depends on the burn area. Okay, yes. All right. Which visitor action requires correction for a neutropenic client? All right. So which visitor action requires correction for a neutropenic client? So if you have a patient that is neutropenic and you have visitors coming in, which of them would you say, hey, no, that's not allowed? All right. The patient wearing the person wearing a mask, bringing in fresh flowers, washing hands before entry, or sitting 3 feet from the client. So which action by the visitor requires you to correct them? Remember, this patient you have is neutropenic. All right. And what we know about neutropenia. So no flowers or fruit, B, no flowers. Okay. What we know about neutropenia. High risk for infection. Definitely. So you want to hold off on anything like that. If they're wearing their mask, that's good. Washing hands before entry, that's a plus. And sitting 3 feet from the patient, that's a plus as well. You understand? Because at least you know that if you have any form of infection, if you're coughing, and then if you're coughing, you know, definitely stay away from those kind of patients. You understand? You can always wear your mask, but I don't think it's a dire emergency for you to visit like that. So if you're sick, you just stay away from those patients just to protect the patient. All right. For once, just try not to be selfish and go in there and introduce whatever you're having to those patients. All right. Low blood cell count. Yes. Is the Saunders? No, Kai. No, it's not. No, it's not Saunders. These are just like some random questions I got. Yeah. All right. Different questions. All right. So which finding shows improving ventilation in an asthma patient? Oxygen saturation of 90%. Decreased wheezing. You have questions that are Saunders like these. Okay. So which finding shows improving ventilation in an asthma patient? Oxygen saturation of 90%. Decreased wheezing. Increased peak expiratory flow, or diminished breath sounds. All right. So which finding shows improving ventilation in the asthma patient? Is it the oxygen saturation of 90%? C. Decreased wheezing. Is it the increased PEF or the peak expiratory flow rate? Or is it diminished breath sounds? Marva says D, diminished breath sounds. Remember the word improving. All right. Improving ventilation. C. Okay. Decreased wheezing. Okay. B for real. Okay. B for real. All right. So which finding shows improving ventilation in the asthma patient? O2 sat of 90%. Is that acceptable? Well, it depends on where it's coming from, you know, because you might have a patient coming from 65 and you're at 90, you know, that is acceptable at that time. All right, but we're just going to use what we have here. So oxygen saturation of 90%, is that acceptable? No. Okay, increased peak flow, definitely the peak flow. Decreased wheezing. So which finding shows improvement in ventilation? Is it decreased wheezing? Yes, we usually say that, but the standard is when you have your peak flow. All right, so always get your peak flow on these patients and see where they're at, and that usually helps with telling you how well they're doing. All right, diminished breath sounds means that, you know, you go in the opposite direction. All right, so definitely you want to get your PEF, because that is one way for you to measure how well the patient is actually breathing, their airway status. All right, so definitely do that. All right, so A client on spironolactone should avoid bananas, apples, rice, grapes. So I have a patient that is on spironolactone. Which food should they avoid? Is it bananas, apples, rice, or grapes? A, bananas, grapes, banana. Okay, definitely, because what we know about spironolactone, bananas. So spironolactone, what it does, we talk about the Lasix or the furosemide earlier, where you lose your potassium. Okay, you lose all your potassium. But with this one, it's the opposite. It spares it, so you will tend to have a lot of potassium on board. So you definitely want to encourage the patient to avoid anything that is high in potassium because of the risk for hyperkalemia. All right, so apples, grapes, and your rice are pretty good. All right, so definitely avoid your foods that are high in potassium. Yes. All right, let's try some. All right, are we holding on? All right, let's try some. I think we did one question like this. Which medication is the antidote for opioid? You can just write it there. I'm not going to give you the 4 answers. Just write it there what you think. So if a patient that comes in with an overdose and you're suspecting it's a narcotic, what medication are you going to be giving? Your naloxone, definitely. All right, definitely, yes. So the answer we have here would have been the flumazenil. You have a naloxone, your protamine, definitely, yes. So the answer we have here would have been the flumazenil. You have a naloxone, your protamine, sulfate, and your vitamin K. All right, so definitely your Narcan. A client taking warfarin should avoid which of the over-the-counter medication? Is it acetaminophen, ibuprofen, loratadine, or guanfacine? So a patient is taking warfarin. What medication should they avoid? Is it the acetaminophen, the ibuprofen, the loratadine, or the guanfacine? Ibuprofen. Okay, nice, nice, and welcome, Nisia. All right, do we have anybody else who want to compete with Nisia? B. Okay, B. Yes, definitely. Do we have anybody on YT? Ibuprofen, definitely, because we know that ibuprofen is what class of drug? B. Okay, so we know that it's an NSAID and you're at risk for your GI bleed. So you don't want to give a patient or encourage a patient that is already taking a blood thinner to, you know, be taking NSAIDs as well because of that risk for bleeding. All right, so always remember that. All right, so it increases the risk for bleeding with warfarin, so avoid that. Acetaminophen should be fine. Loratadine, guanfacine should be okay. All right, nice. Which teaching is appropriate for a client prescribed levothyroxine? And we know that levothyroxine is used to treat what? What we use levothyroxine for? The thyroid. Okay. Anybody on YT? Hypothyroidism? Definitely. Hypothyroidism. Hyperthyroidism. Okay. All right. So use it to treat your hypothyroidism. Hypothyroidism. All right. So definitely you want to go ahead and teach. You want to go ahead and tell the patient to go ahead and take it with food in the morning. Is that the answer? Take it in the morning on an empty stomach. Take it only with symptoms. When symptoms are happening, or stop once the symptoms have improved. Which of these would you tell the patient? So you give the patient the medication and you're educating them. What teaching would you give them? Do you tell them to take it with food in the morning? Take it on an empty stomach? You know, take it only when the symptoms are there, or stop once the symptoms have improved? So I see Marvia says A, take it with food at bedtime. Okay, do we have anybody else? Take it with food. Anybody else? So that's one medication. I always tell them take it very, very early in the morning. All right, take it on an empty stomach in the morning time because it's best absorbed, or absorption takes place a little bit easier at that time in the morning. So definitely B is going to be the answer. Take it with food at bedtime. No, most of the time your cholesterol medication, you take at bedtime. You have other medications that you'll take, but no, Marvia, I still want you to answer. But the answer is, take it on an empty stomach in the morning for better absorption. So a lot of times you'll hear people say, oh, they take it at 5 o'clock. Some people say they take it from 4 o'clock. You understand? But the empty stomach is best for that one. Stop once the symptoms improve. Do you want to tell these patients to stop taking it once their symptoms have improved? No. All right. Once they start on their levothyroxine, it's going to be something that is going to follow them for years to come. All right. So we'll continue with monitoring their labs to make sure that the numbers are good and the dosage is correct to maintain their levels. All right. Take only when the symptoms occur. No. All right. They're going to be on this medication for life. All right. Take with food at bedtime. As I said, no, you always want it in the early morning. Talking about, no, Marvia, I want you to stay on the live. All right. The nurse is monitoring a client on gentamicin. Which finding is most concerning for this patient? We know that gentamicin is what? It's an antibiotic. All right. So anything with mycin, what class of drug is that? Someone needs to study more. I think all of us need to. Oh, Lord. The nurse is monitoring a client on gentamicin. Which finding is most concerning for that patient? So it's an antibiotic. All right, no problem, Machiavelli. All right, no problem. So it's an antibiotic. We definitely know that, and it is an aminoglycoside. All right. So always look at the end of the drug, and usually you'll be able to put them in their different classes, especially the antibiotics. All right. So gentamicin is aminoglycoside, and one thing that you'll hear a lot of times they say is that it causes what? Tend to cause this problem with what?
Who is this guy?
Let me see before I start giving the answer. You've heard about gentamicin, right? The ear, yes. All right, so the nurse is monitoring the client on gentamicin. Which finding is most concerning? Is it A, headache, B, ringing in the ears, C, mild nausea, or D, increased appetite? So ringing in the ear, tinnitus, definitely, yes. So you try to remember the different medications that cause, like your nephrotoxicity and ototoxicity. And always, gentamicin is one of them. I think I learned that when I was doing peds rotation, when I was doing my RN or my bachelor's at that time. Yeah, I was on the pediatric floor, and that was one medication that they had, but a lot of doctors were a bit hesitant to use it because of the risk for problems with the hearing for those kids. All right, so ringing in the ears, aminoglycosides cause ototoxicity, which is the ringing in the ears, the tinnitus, or hearing loss. All right, so sometimes patients will have headaches. I'm not so sure if with the gentamicin, if that is something that is common. But it depends on the medication that you're giving. You understand? Mild nausea, a lot of patients will tend to have nausea or GI effects with their antibiotics. So that is not something that is like, super concerning. You definitely want to address it, but it's not like, something that is like, oh yeah. If you start a patient on a medication and you realize that they start having ringing in the ears, you definitely want to go ahead and address what is going on. Figure out if it is a medication that is causing that. Vancomycin tends to cause some, like, some persons will tend to have like sensitivity in the head, like, redness in the head and all. So you definitely want to like turn down the rate or stop the medication if. So it's the same thing with your gentamicin. If you notice their symptoms or signs that develop as soon as you start the medication, then that is concerning for you. All right. Increased appetite. I don't know which medication, like, but you have your regular medications out there that will increase your appetite, but that is not something that you're going to be like super concerned about. All right. Another last resort. Yes, definitely. So which lab values, here's a vancomycin question. Which lab values should be monitored closely with vancomycin? Redman syndrome. Yes, definitely. All right. So the redness in the head, the Redman syndrome that is associated with the vancomycin. All right. So which lab value should be monitored closely for a patient on vancomycin? Is it the hemoglobin, creatinine, the sodium, or the potassium? So if you have a patient on vancomycin, which lab value will you be monitoring? Is it the hemoglobin, creatinine, sodium, potassium? All right, Chelsea says sodium, okay. Creatinine, okay. All right, so the answer, just a girl says sodium. Okay, so the answer is actually the creatinine B because of the risk for nephrotoxicity. All right, so as I say, remember the different medications that cause your ototoxicity and your nephrotoxicity. All right, your aminoglycosides tend to cause problems with your hearing and your kidneys as well. So definitely you want to look at those lab values. All right, your vancomycin is nephrotoxic, so monitor your kidney functions. All right, so make sure you're looking at their creatinine and all. A client is prescribed lisinopril. Which lab value, or a client prescribed lisinopril should be monitored for? Is it hypokalemia, hyperkalemia, hypernatremia, or hypertension? So a client is prescribed lisinopril, which is a blood pressure medication. What would you be monitoring for? Is it low potassium, high potassium, high sodium levels, or the blood pressure being high? Hyperkalemia, okay.
3, 2, 1.
A, hypokalemia. Last one, hypertension, high potassium, definitely. So the high potassium, because you know with the ACE inhibitors, they tend to cause potassium retention. They retain a lot of potassium, so definitely you want to go ahead and monitor for that. All right, so no, not the low potassium, it's the high potassium. All right, so remember the class of drug, and then once you understand the class of drug, then you'll be able to answer the question. All right, so a client with lisinopril should be monitored for low potassium, high potassium, high sodium, or for hypertension. The answer is going to be the high potassium because of the ACE inhibitor that cause potassium retention. All right. The nurse is given digoxin. Which parameter must be checked first? You can go ahead and type the answer down below without me saying. So you're going to give a patient a digoxin. What is it that you're going to be doing for the patient before giving that patient? Okay, you're going to check the heart rate. You check the pulse, definitely. Heart rate, okay. And if the heart rate is 50, would you give the patient a medication? Radial pulse, okay. No. So the pulse rate needs to be at what rate for you to give it? At least 60, yes. So anything above 60, you give it. And then 60, just the girl says 100. So 60 and above, all right? 60 and above, definitely go ahead and give that medication, and you withhold it for that. Always think about the normal heart rate. What is normal heart rate? 60 to 100. So definitely, you know, once you have that and you're using it, you know, it will help with guiding you. But definitely you want to go ahead and check your apical pulse. And if it is below the 60, you withhold it. Respiratory rate, temperature, oxygen saturation, those were the other findings. A, respiratory rate, B is apical pulse, C, temperature, oxygen saturation. So what parameter must the nurse check? It's gonna be your apical pulse, all right? Because it's gonna cause the what? The bradycardia. All right. Which finding, all of the, and above all, okay. All right, which finding a client on metformin requires immediate, which finding in a client on metformin requires immediate report? Is it a patient that is having like headache, muscle pain, lactic acidosis symptoms, or mild weight loss? So if you have a patient that is on metformin and they start reporting any of these, which one of them requires you to report it immediately? Is it if you're having the headache, the muscle pain, the lactic acidosis, or the mild weight loss? So lactic acidosis, first one, headache, muscle pain. Okay, I think I saw one person, somebody says lactic acidosis, yeah. All right. C, lactic acidosis. So yes, the answer is C, the lactic acidosis, because that is one of the rare life-threatening causes of metformin. All right, so headache, you want to require immediate attention if you're giving a patient metformin. Muscle pain, it depends. You can always still monitor the patient for that. Your lactic acidosis, definitely, if they're having symptoms of that, then definitely you want to go ahead and address it. Hypoglycemia, okay. Well, that one wasn't there, but yeah. If they're having hypoglycemia, then definitely, you know, you want to address that as well. Mild weight loss, a lot of patients tend to, you know, lose weight with metformin, so that's not something that requires immediate, you know, reporting. All right, so metformin can rarely cause life-threatening lactic acidosis, so definitely go ahead and address that. All right, a client taking Dilantin as swollen, bleeding gums. What teaching is needed? Is it increase the vitamin C? I got it. Increase vitamin C intake. B, perform good oral hygiene and regular dental visits. C, stop the medication immediately. Or use only soft foods. So a client is taking Dilantin or phenytoin and they have swollen, bleeding gums. What teaching is needed? Is it to increase? Thank you.
Okay, got it.
Is it to increase the vitamin C intake? Increase vitamin C intake. Perform good oral hygiene and dental visits. Stop the medication immediately or use only soft foods. Stop taking the medication and then the patient start have seizure on you. It makes sense to make the patient have the swollen gum. Huh? Which one do you want to take care of? The swollen gum or the seizure? Dental hygiene, definitely. Soft brushes, definitely. So dental hygiene. Yes, always think of the question, you know, when you're answering the question, just think of it. If I stop this, am I willing to deal with the complications of not having that going at the time? You understand? So if you immediately stop the medication, there's a chance the patient is going to start having seizure. So do you want to deal with the seizure or do you want to deal with the swollen gum or, you know, whatever else is going on? So definitely the oral hygiene and dental visit is what you would be concerned about, because, you know, they tend to have, a lot of times they tend to have like a buildup of like gingiva. Yeah, so you have like a buildup of that, and so that is a concern a lot of times. You want to make sure that they're having good oral care in the hospital. All right, so increase vitamin C. You can give you regular vitamin C. Stop the medication immediately is not what you want to do. All right, you don't want to do that. You want to continue your medication because you don't want the patient to start having seizure if you start, you know, if you discontinue their medication. Use only soft foods. Yeah, you want to give them soft foods, like, you know, because of the swelling. So definitely you'll do that. But out of all of these, definitely you want to encourage a patient to go ahead and you know, practice good oral hygiene and do regular visits at their, you know, with their dentist. Soft brush. Yes, can you be my patho professor, please? Oh, Lord. I will try as best as I possibly can to help you. All right. All right. So, which is a priority assessment before giving morphine? And what we know about morphine, it's a narcotic as well, right? So, which is priority assessment before giving morphine? Is it A, the heart rate, B, the blood pressure, the respiratory rate, or D, the temperature? So you have a patient that you're going to be giving morphine to, and you realize that the patient is breathing at 8 breaths per minute. Will you give the patient that medication? So respiratory, heart rate. Okay, so what does, so C, okay. All right, so what does heart rate? All right, so first you have to look at, you know, what morphine does. Morphine causes respiratory depression. All right, so definitely if you see the patient breathing at 8 breaths per minute, anything below, you know, not at 8. Anything below 12 breaths per minute, you definitely want to go ahead and withhold that medication. All right, so definitely withhold that medication. So where is it? So morphine causes respiratory depression. So definitely you'd want to observe that, and then from there. All right, and if you realize that, you know, so for example, the patient come in and they're on overdose with morphine and they're breathing at the 8 breaths per minute, you know, what medication will you go ahead and give them to help with that, to help with correcting that? Barcas. So if you have a patient that has a narcotic overdose, what medication would you give to correct that? Barcas again, Narcan, okay. Naloxone. Okay. Yeah, so you'll go with your Narcan. Barcas, naloxone. Barcas. Someone wanna give me some things here for research. Let me see what that is. Let's see what Barcas. Okay, I'm not familiar with that one, but okay. Leave that Zarian. All right, sorry. Yeah, so your naloxone, your Narcan, definitely you want to go ahead and help with reversing that. I was looking up the Barcas that I see. I don't know who had typed it in. User 6602. Barcas 600 prolonged release tablet. Oh, something like Toradol. Okay, well, that's not the answer. Okay. That one is not the answer I was looking for. All right, so definitely you'll do that, but let's go back to that question. All right, so the respiratory rate, as we say, is the priority assessment for that patient because the morphine causes respiratory depression. All right, a person that is taking long-term prednisone should be monitored for what? Hypoglycemia, infection, bradycardia, or hypotension. So if a patient that is on long-term prednisone, what will you be monitoring that patient for? You get the lab results and you look in. What is it that you're more concerned about for that patient? In terms of like your lab results, Nisia says infection. Anybody else on YT? Welcome, welcome. Anybody else want to say, I think infection? Definitely, because you know those persons are what? Or the steroids, what it does, it suppresses your immune response. So definitely you want to look at their white blood cell count. So the client on receiving long-term prednisone should be monitored for A, hypoglycemia, B, infection, C, bradycardia, D, hypotension. So they're immunosuppressant, yes. So definitely the answer is the B, which is the infection, because corticosteroids suppresses your immune response. And will that patient be hypoglycemic? Is that patient going to be hypoglycemic, as in low glucose they'll be having, or will they be having high glucose levels? They'll be hyper. All right, so high, yes. So the answer is going to be the infection. They're not going to be having the hypoglycemic. It's going to be hyper. All right. Which teaching is most important for a client prescribed alendronate? Is it to take with orange juice, remain upright for 30 minutes after taking the medication, chew the tablets thoroughly, and take at bedtime with milk? And usually when do you take alendronate? So remain upright for 30 minutes. Why is this patient taking alendronate? So remains upright, definitely. Osteoporosis, definitely. So you want to make sure that they're taking it and remaining upright after taking the medication. All right. So a lot of times these patients will have bone loss. Yes, it's for bone loss. So you want to make sure you go ahead and monitor like their calcium levels, get their have them do their bone density test, and then from there, what the numbers show, you go ahead and just start them on those medications to help with that, because you don't want them to start having, like, you know, the fractures and all. Give me 1 second, please. All right, so sit upright for 30 minutes. Okay. All right, so alendronate works by slowing the natural process of bone breakdown in the body. All right, so definitely you want to go ahead. It belongs to the class of the bisphosphonate, and this drug is primarily used to treat and prevent osteoporosis and other bone disease. All right, so definitely you want to go ahead and do that. What's the main reasoning behind them sitting up after taking that medication? Why do you have them sit up for 30 minutes after taking the medication? The GI issues, yes. Okay, so a lot of times they tend to have esophageal erosion because of that. So you want to make sure it stays down. All right, severe corrosion. Okay, definitely. All right, so they take the medication, lie down to prevent all of that. All right, so that one is correct. So chew the tablets thoroughly. What do you tell them to chew the tablets? Take at bedtime with milk. And would you encourage them to take it with milk? Never, never, yes. All right. If they take it with milk, what happens though? Not at bedtime. Can they take it with milk? A lot of medications, when they take it with milk, it decreases, yes, it decreases the absorption. It binds to it and then decreases the absorption, so it's not that effective. So usually you want to make sure that they take it with their water. All right, so definitely go ahead and encourage them to not take it with milk. All right. The nurse is monitoring a client. Oh no, I think we did that one already. Let me go down here. A nurse is preparing to administer IV potassium chloride. Which is correct? Is it give undiluted, IV push, infuse slowly using a pump, mix in dextrose solution only, administer IM if IV access is unavailable? So you have a patient that is, you're preparing the IV potassium. What action is correct? Giving it undiluted in IV push, infuse slowly using a pump, mix in dextrose solution only, administer IM intramuscular if the IV access is unavailable. All right, so let's hear the answers here. Never free flow, slow IV infusion. Okay, do we have anybody on YT that wants to give an answer? So even what if you're going, you realize that the potassium is 1. You realize that the potassium level is 1. You look at the labs and you see that the potassium is 1, and the doctor say, go ahead and administer the potassium. No, what will you do? You see 1.0 and the doctor put up the order. What will you do? Slow IV push. Patient is having arrhythmias, and you know that the arrhythmias is because of the potassium being low. What is it that you're going to be doing? You're going to be IV pushing it, or you're going to be slow pushing it? Slow IV push, never free flow or push. So what happens if you push it? Yes, cardiac arrest. IM if you can't. IV. Huh. Shells? You sure? You sure about that one there? Serious arrhythmia potentially. Yes. So definitely that is one medication. Your erosion of the blood vessel. Yeah, you're going to have erosion of the blood vessel, but then erosion of the blood vessel is not even something we even be concerned about right about now. If you decide to go ahead and push that, yeah, man, your license, you gonna prison back way. You understand? You don't want a patient to go into cardiac arrest. So never go ahead and IV push that medication. That is one medication you want to double check, triple check, full check. Yeah. So those are one of your high risk medications. So always find somebody else to double check it with. All right. Your insulin, your potassium, some of your cardiac medication, and a lot of times, even with the cardiac medications, even if you're using it over and over, it doesn't hurt, you know, just having someone check with you. All right, but never go ahead and push your IV potassium, regardless of how low the potassium is. Never go ahead and push it. All right, and don't do IM with it either. You want to go ahead and set it up. Take your time and set it up. Make sure you have the correct drip rates, or the pump is actually set at that, and you run it over the designated time period. A lot of times the patients might have, like, you know, the burning or irritation at the site because of, you know, how corrosive it is. You understand? So it tends to damage their veins there. So you want to make sure you go ahead and add fluids to kind of help with preventing that. Sometimes even if the potassium is very low, you might end up having to prolong the period. If you can't get a central line, you have to go ahead and prolong the period in which you would have to infuse it, but you're not going to increase the speed on it. Not going to change the rate on it because you don't want to put the patient in arrest or any arrhythmia because of that. All right, so never rush with your potassium. You understand? Because you'll be causing more problems for the patient as well as for yourself if you do that. All right. So if the nurse is preparing to administer IV potassium chloride, which is correct, give undiluted IV push. No, you always mix it. You always dilute it, you know, and you go ahead and you hang that bag and you run it over your 1 hour, and from there, all right, infuse slowly using a pump. That is the right thing to do. Mix in dextrose solution only. Administer IM if IV access is unavailable is a no-no. All right, so definitely not that one. I don't remember if it is dextrose they use or a dextrose with normal saline. I don't remember, or if it's just straight normal saline. I think it's just straight normal saline. Whenever you're not so sure which medication to go with, it's always good to go with your isotonic. So your saline, your normal saline, yes, it's always good to go with your normal saline because the isotonic is almost the same as your blood. So always go with that whenever in doubt. All right. So never push your IV potassium. It must be diluted and infused slowly. All right. And make sure the patient is on a pump, a cardiac monitor. You don't want to leave that off. Always have the patient on a cardiac monitor. If you don't have a cardiac monitor, go and find one somewhere. Get the patient hooked up. If you have a patient in a bed that is on a cardiac monitor, switch out the patient from out of the room and make sure you hook up that patient on that cardiac monitor. All right, you can't be running your potassium and the patient is not correctly, you know, hooked up. Make sure you get your EKG as well because you want to know what their baseline is, and then you start your potassium. All right. And if it starts burning at the site, and you know, you're wondering, oh, should I go ahead and whatever, discontinue that one, get a different IV, but don't go ahead and try to flush it in because it's going to cause further. Just go ahead and take out the IV and, you know, just leave it there. Because remember, whatever is in the tubing, you're running it in. And you don't want to, when you look on the monitor, you see the patient heart rate in the 150s and you're wondering, oh, but I stopped the potassium. No, you stopped the potassium, but you're flushing it. You're flushing whatever is in the tubing into the patient's, and you can't put the patient in, you know, severe arrhythmia. So never do that. Go ahead, take out the IV if it is burning them. But I always say leave the IV until you get the other one because it's still a route to the patient's heart. You understand? Always go ahead and you can always pull back, take out that blood that is there. Then you flush your line. So you waste whatever you pull back. So you can always go ahead and pull back like a 5 mils, waste it, and then you flush. If it is a case you have to keep that IV. But I always prefer to have an IV there, then go ahead and get my second IV. If I'm able to get a second and a third IV, then I will do that and then remove that one. But I'm not going to be removing that one because it's burning at that time, especially if the patient is a hard stick. Get that IV first and then from there. If you're having problems, always try to get one of the big ones. You understand? Always get one of the bigger ones, the IVs, your ACs, your 18, 16, 14, and then from there. If you're having problems and the patient is still burning, you know, having burning, irritation, go and tell your doctor. Let them try to get a central line because it's very painful for the patients. And you don't want to be a case where the potassium is so low and you're taking 2 hours to give 1 bag of potassium. You understand? No. You're putting the patient at more risk for other things. So definitely have them try to put in your central line and infuse your potassium at the, you know, the correct time to make sure that, you know, the patient doesn't get into any arrhythmia. All right. So that's why they leave IV in the hand, right? Not all. Well, you always want to have an IV in place for your patients because remember, that is the quickest way to get to the heart. If the patient code on you, that's the fastest way for you to get your adrenaline, your epinephrine in. You understand? Just imagine you have a patient and you take out the one IV. Even if the IV is leaking, there's a possibility that the medications can still go in the vein. You understand? There's some that might go in. So I am not always quick with taking it out, especially if they're hard stick. I usually get that new one going first and then I'll remove it. You understand? Because I don't want to be a case where I leave the patient without anything and then the patient codes and you're trying to get an IV and you can't get it in. I just think that even if it is leaking, it's still, there's some that is going to go in the vein. You understand? Some is still going to go in the vein and it will still save the patient rather than not having anything. At least you try. So that's just it. But when you have those patients, you know, before they start, you know, decompensate, I always try to go ahead and get 2 IVs. Let them know from before that this is what is happening. You're very sick. We're going to give you multiple medications. You know, they might be contraindicated, you know, if you run them together. So you always want to have like your 2 IVs. So my patients always have like a 2 ACs, and that's it. So if they order a lot of medication, I can always go ahead and hang, you know, their 2 antibiotic, as long as I don't start it at the same time. I can always go ahead and hang multiple drugs, you know, and monitoring them at the same time. So that's why they leave the IV hemlock. Okay, yes. All right, so definitely do that. The nurse is teaching about levodopa. Which dietary instruction is correct? Avoid foods high in B6. Take with high protein meals. Eat grapefruit daily. Increase sodium intake. All right, this one is not my... I don't know much about this one, but the nurse is teaching about levodopa. Which dietary instruction is correct? Is it avoid foods high in vitamin B6? Take with high protein meals? Eat grapefruit daily? And increase sodium intake? Who knows that one? All right, so the answer is gonna be, I'll just tell you the answer. The answer is gonna be the avoid foods high in B6, because it can cause decreased effectiveness of the drug. Oh, 660, sorry. Yes, all right, yeah, so that's the correct one, avoiding the B6. All right, so with them, you should be able to take high protein meals. They can eat grapefruit daily, and they can increase their sodium intake. All right, but you need them to avoid foods that are high in B6. All right, the nurse is preparing to administer intramuscular alloperidol. Which condition is the greatest concern for this patient? I don't know if Shells want to come up here. I see an invite, so let me send it. I don't know. The nurse is preparing to administer intramuscular alloperidol. Which condition is the greatest? Oh, okay. Is it the sore throat, muscle stiffness and high fever, weight gain, and constipation? So you have a patient that you're going to be administering intramuscular alloperidol, and that's one of your antipsychotic medications. Sometimes they use it for nausea as well. Which condition is the greatest concern? So, and I always say, if you don't know the medication, just look at, the answers and then choose the one that is, life-threatening, the one that is very risky, the one that you can't deal with. You understand? So is it the sore throat? If you have a patient with a sore throat, is that something that you'll be like, concerned about for this patient? Is it the muscle stiffness and the high fever? Is it the weight gain? Is it constipation? Weight gain usually takes a little while, for that to happen. The constipation, the sore throat, a few hours a day or so. Muscle stiffness and high fever. So you're gonna give this patient at the hospital, so BB, okay, which is the muscle stiffness and the high fever. And why are you concerned about that one? What condition are we thinking about? So the muscle stiffness and the high fever is concerning for what condition? A lot of times you hear they talk about it with the psych population. Dystopia. We have anybody else? TD. That's tardive dyskinesia we're talking, right? Dystonia. No, we're talking about the neuroleptic malignant syndrome, where you tend to have the fever. So a lot of times, whenever you have a question with psych, most of the time the question always is with that one, and you always have the fever with it. So they tend to have the stiffness in the legs and the fever. Okay, Shauna says, okay, yeah. So always look at that answer. Anytime you see that is a symptom, yes. All right, so anytime you see the patient having the fever and the muscle stiffness, then you're always thinking about that. All right, the neuroleptic malignant syndrome, and that is very life-threatening. So be concerned about that. So if that patient is a psych patient, or then definitely you want to be concerned about that. The sore throat, you'll be concerned about sore throat as well. All right. The weight gain, a lot of times, if you have a patient that is who is on a lot of the psychotic medications or antipsychotic medications, they tend to have on a lot of weight because I don't know, but yeah, a lot of times they tend to be eating a lot because that's what the medication tend to do as well. So they tend to put on a lot of weight. Constipation, I think when you're depressed, sometimes you probably don't want to drink a lot of fluids, so that probably puts you at risk for the constipation. But for the alloperidol, or if you have all of these, the one that is most concerning is the muscle stiffness and the fever. All right, so your neuroleptic malignant syndrome, which gives you the rigidity and the fever, it is very life-threatening. All right, yes. So which medication can cause tendon rupture as a serious adverse effect? Is it ciprofloxacin, amoxicillin, azithromycin, and ceftriaxone? Which medications, sometimes you hear they say, they don't want any problems with the Cipro. Okay, they don't want any problems with their, especially the athletes. Sometimes they hear they say they don't want that medication because it can cause problems with their tendon. Cipro, okay. So yeah, your ciprofloxacin, anything with your quinolones. So your fluoroquinolones, like your ciprofloxacin, tend to cause, problems with your tendons. So you have to be very, very careful. So if you hear a patient saying that you order the medication and they tell you that, their ankle is they're having pain, irritation, and it started since the medication, discontinued the medication, because most of the time it's the ciprofloxacin that is causing it. All right, so you can have tendon rupture because of that. Amoxicillin, we tend to give it a lot, but that's not one of the main, the warning that is associated with that medication. All right, azithromycin, ceftriaxone. So your ciprofloxacin or your fluoroquinolones are the ones that carry this black box warning. So just be mindful of that. All right. And most of the time when you have questions coming, it's the same thing they always talk about. It's either they ask you about fluoroquinolones or the Cipro in terms of with that tendon rupture. All right. A client is taking rifampin should be taught what? Your urine may turn orange-red. Avoid vitamin C. Report constipation immediately. Take only with milk. So you have a client that has rifampin, and which condition usually you use that for? So you have a patient that is on rifampin. Which condition you normally take that for? Cirrhosis, TB. Okay. Anybody else with another answer? So your tuberculosis, yeah. So your tuberculosis, they normally they have this combo. So you have to try and remember the names. But the rifampin usually gives you the orange color urine. All right. So if the patient says that, and sometimes when the patient comes into the hospital and they tell you, then depending on the color, sometimes you can know that, they're on this kind of medication. But the rifampin is one medication that tends to cause the orange-red color. You also have, sometimes the patient will tell you that you take it whenever you're having like UTI symptoms. Pyridium, they tend to have the orange or orange yellowish color as well. So depending on the, sometimes they'll tell you that my urine is looking orange red or it looking blue, then you may be able to, it's for liver. TB, so it's used for TB, tuberculosis. So definitely, you can use the urine color to kind of tell what medication. Sometimes they might not be able to tell you the name of the medication, but sometimes, if they say, it looks very bright yellow, then you can always say, okay, then this is what it is used for. Let me look up something here. So let's just pull that up. But there you have the isoniazid. Not a problem, the traveler. Thank you so much. Thank you. But you have the isoniazid. You also have the rifampin, and there's another one that they always be putting in with the question. So let's look at it. So let's try and remember those 3 or 4. 4, 2. Okay, so you have the rifampin, the isoniazid, the ethambutol, moxifloxacin, but I know the rifampin, the ethambutol, the isoniazid are the 3 most commonly used one. The I think pyridoxine. For what? For the color or for the TB? Yes, moxifloxacin is an antibiotic. Yes, for TB. So you have ethambutol, isoniazid, moxifloxacin, rifampin, pyrazinamide, and so I think zinamide you're talking, and the rifapentine. Yes, color orange. Yes. All right. So, where was I? Did I mess that up? Rifampin color change. Yes. The color changed to orange. Orange, reddish color. Let me try and find back the question that I was at. So let's try and remember those medications. Hold on 1 minute. Okay, all right. So your urine may turn orange red, causes color change too. Yeah, but what color does that one change it to? The pyridoxine, pyroxidine. What color it changes it to? So if the option is there, but they ask specifically for rifampin. So I guess if they put, you know, whatever other medication, then you'll choose the one that is there. All right, so this one says it turns your urine orange red, which is something that, you know, you'll always hear the patients talk about. Oh no, it's not for color. Okay, yeah. All right, so avoid vitamin C. So harmless discoloration of the body fluids is expected. So report constipation immediately. Yeah, that's time to drink some more fluids. All right, so the standing answer is the rifampin changes the color to orange red. So your urine may turn orange red. That's the answer. All right. Take only with milk. As I say, a lot of times you don't want to encourage patients to take any medication with milk because it causes problems with absorption. All right. Hi, Big Muscle Travel and Adventure. Welcome, welcome. Okay, no problem. All right, which teaching is correct for a client on sucralfate? Is it to take with meals, take on an empty stomach, take with antacids at the same time, or chew the tablets thoroughly? So I have a patient that is taking sucralfate. What teaching is correct for this patient? Is it take it with meals, take on an empty stomach, take with antacids at the same time, or chew the tablets thoroughly? On an empty stomach. Okay. Do you have anybody else with another answer? Empty stomach to coat it, definitely. So you want to take it to coat the stomach. So you take it before meals, and then, you know, they can go ahead and eat. All right. So that's the correct answer. So it works by coating your stomach lining, and it is taken before your meals. All right. Would you take it with antacid at the same time? No? Okay, why you want to take it with the antacid? You could? Okay, but why you want to take it with the antacid though? Okay, yes, it's gonna counter the productivity of that. Okay. Yeah, so definitely you don't want to take it because you'll be counteracting what what you'll be doing. So you can always go ahead, let them take it, protect the lining, and then later on, if you need to take your your antacid, they can go ahead and take it at that time. All right, but definitely have them take it first and help with coating that stomach lining, protect it a little bit. All right, and then later on, if they want to go ahead and try their antacid, then they can go ahead and do that. All right. Which is the priority assessment for a client starting atenolol? And what class of drug is atenolol? Your LOL drugs, your beta blockers. Okay. All right. So which is the priority assessment for... They both quote the stomach lining and stuff. Yeah, but then remember the antacid is gonna help with what? It's gonna coat, but then remember the antacid is gonna help with the hydrochloric acid as well. So if you can coat it first, protect it, and then later on you take your antacid, it will help with that a little bit better. But you don't want to take both of them at the same time. So go ahead and coat, and then you take your antacid later on. No? The antacid is going to help with slowing the production of your slow the production of your hydrochloric acid. All right, so you take your sucralfate first, protect your stomach lining, and then later on, if you're still having the heartburn and whatever, you can always go ahead and take your antacid. But as I say, usually you don't want to be taking both of them because you'll be counteracting with. But if you feel as though later on you're still having, you can go ahead and take it. Like a 20-month-old after. Explain that for me, user. What if it's a standing dose? If what is a standing dose? 20 minutes. Just don't go ahead and give both of them at the same time. All right, just don't give both of them at the same time. Routine dose of both meds. If the routine dose of both meds, usually just give one. You can give one 30 minutes later, but I wouldn't give both of them at the same time. Give one first. I would give the sucralfate first, help with coating the stomach lining, so that way whenever and then later on probably I'll give the antacid later on. But I want to give both of them at the same time. All right. B. Okay. All right. Welcome back, Kai. Welcome back. All right, so B. All right, so which priority assessment for a client starting atenolol is important? Lung sounds, the heart rate, the reflexes, or the sodium level. So the heart rate, B, because it's a beta blocker, so it's gonna cause what? Is it gonna increase the heart rate or increase the heart rate? Lower it. Okay, yes. What if you had hypoglycemia? What if you had the glucose there? Would you be concerned about that? What if they never had heart rate and they had, which priority assessment for the client starting atenolol is important? Your lung sounds, your glucose, low glucose, reflexes, sodium. Would you be concerned about anything there? Does the beta blocker affect your glucose level? Yes, Shana. Yes, it does cause, you know, it lowers your glucose level as well. So just be mindful when you're giving the medication. You know, your patient might become hypoglycemic as well. It might not drop it significantly, but I'm just saying, if you never had the heart rate, the primary one would have been the heart rate. But what if they are tricky and just say, all right, let's put the glucose there. As long as you know what, you know, sites your beta blockers are working on, then you'll be able to answer the question from there. All right. Lung sounds, no. It wouldn't be the lung sounds. All right. So if they had the glucose there, then you'd check that one as well. All right. So beta blockers decreases your heart rate. So you hold it if it is less than your 60 beats per minute. All right. A client is taking allopurinol. The patient is taking allopurinol. What condition we use that for? The allopurinol. Gout. Okay. Yes. Yes, it is gout. All right. So a patient is taking allopurinol for gout. Should be instructed to drink plenty of fluids, limit dairy intake, take with grapefruit juice, avoid all exercise. So you have a patient that is on allopurinol for gout. What will you tell them? Drink plenty of fluids, limit dairy intake, take with grapefruit juice, or avoid all exercise. So Kai says A, drink plenty of fluids. Do we have anybody else? Beer intake, fluids. Okay. All right, so definitely go ahead and make sure you're drinking a lot of fluids. To help with what? Why are you telling them to drink a lot of fluids? What are they at risk for? So you have a patient that is on allopurinol. What are they at risk for? Your kidney stones. All right. Acidosis. Okay. I was looking more for your kidney stones. No right answer. So they are more at risk for your kidney stones. So you have to be careful. So diet is something that you want to preach to them and tell them, look, make sure, you know, you're watching the kind of food that you're taking, because then again, you know, the different stones that they can develop. So make sure they're drinking a lot of fluids to help with preventing kidney stone formation. All right. From that uric acid or those uric levels. All right. I have to study more. All right, but as I say, you know, when you're and that's why I always say, like, you're doing the questions, try no wrong answer meant to write at first. You're good. Try to just think about all the other answers, you know, that they have there, and try to just rationalize it a little bit as well. So that will help with, you know, broadening your study as well. All right. Which statement by a client taking oral contraceptive requires further teaching? I should take the pill at the same time daily. Yes, you would. 6602. I don't need to worry about antibiotics interfering. If I miss one pill, I should take it as soon as I remember. I should use backup birth control if I miss multiple doses. So if a patient that is on oral contraceptive, which of these statements by the patient would say that the patient requires more teaching? B for sure, Shauna says, okay. So the answer, I should take the pill at the same time daily. If I miss one pill, I should take it as soon as I remember. I should use backup birth control if I miss multiple doses. All of those are correct. Antibiotics can lessen the effect. Yes. So what are some of the things that can actually decrease the effectiveness of medications? The general things that, you know, they preach every day. So we know antibiotic is one. Which other, what else can cause that? We did say milk earlier. What else? Can corticosteroids, okay. Can grapefruit juice do anything? Like decrease the effectiveness of grapefruit? Cupid says that, okay. Yes. All right, so most of the time, herbal products, definitely. So most of the time, you'll find that, you know, the question sometimes will ask anything like that. So just try and remember some of the different things that can cause, like, overall general decrease in the effectiveness of medications. All right, so look at that. All right, so the patient says, I don't need to worry about antibiotics interfering. Then definitely that patient needs an extra teaching because the antibiotic is going to cause a decrease in the effectiveness of that medication. All right, so you have to be careful with that one. All right. What time is it? 9:20. All right, so a client needs more teaching. Yes, definitely. A client with heart failure has crackles in the lungs and 3+ edema. Which medication should the nurse anticipate? So you're thinking about what medication? So is it lisinopril, furosemide, digoxin, atorvastatin? So the patient is having heart failure. She has crackles and in the lungs and 3+ edema. So Lasix, furosemide, correct. Okay. All right. So definitely you want to go ahead and help with pulling off that fluid. Diuretic, yes. So the lisinopril would be, what class of drug is the lisinopril? ACE inhibitors, yes. All right. Furosemide is your loop diuretic. Would you be concerned about the digoxin? So, you know, sometimes with the heart failure, they tend to have the slow heart rate. So definitely you'll give that. But based on the, you know, the condition, the symptoms of the patient or the signs of the patient, you know, the lungs and the crackles in the lungs and the edema, you definitely want to pull for your fluids first. You want to pull for your furosemide, your Lasix, all right? Atorvastatin, what class of drug is atorvastatin? Your cholesterol medication, yes. And when you're giving your cholesterol medication, what is one lab value? Or, well, you know, you're going to do your regular lab values, but a lot of times patients don't want to be on your cholesterol medication. They don't want to be on any statin. Why is that? What other lab values apart from your lipid panel would you be concerned about for that patient? Your LFTs? Yes. Your liver function, yes, your liver. You don't want to be frying up them liver. All right. So definitely you want to keep a close look on their liver, their LFTs when you're doing their when you're giving them those cholesterol medication. So if you're here to start complaining of any abdominal pain or their urine looks dark or they're complaining about their urine being dark, then you know that's a red flag. Go ahead and get some labs. And the most important thing is to look at their liver, to make sure we're not causing further damage to their livers. All right. Who that they know? Thank you, Luminous, for joining in and for the heart me. All right, so definitely look at that. So the loop diuretic reduces the fluid. All right, so it's going to prevent them from going in fluid overload and the pulmonary edema that they're having as well. All right, so definitely that's the one you'll be anticipating. A client with pneumonia. So what if this same patient with a heart failure that has the crackles in the lungs and the 3+ edema, the patient comes in and the blood pressure is like 50 over palp or 60s over 30s. Patient is hypotensive, but the patient has a lot of fluid and, you know, the crackles in the lungs and edema in the lower extremity. What would you be doing for that patient? Can just type a few things with for that patient. How would you go about with managing that patient? Would you give some fluids to this patient, or what would you be doing? So the patient blood pressure is like so low and you're there and you're still waiting for the doctor to put in some inotrope. Okay. But would you jump to your inotrope just like that? The patient, you just meet the patient and, you know, would you like jump to that at the initial phase, or would you think about, you know, probably some fluids as well? Would you try to still give an extra fluid or not? Because what if you give a patient like, you know, a 250 mils of the normal saline? The patient is hypotensive. Yes, the patient has crackles. The patient has fluids even though they're overloaded. Sometimes you can do that. You'll see providers do that, but it's not going to be much, because sometimes even if you give a patient 100 mils of fluid, it pushes their blood pressure up. So what you'll do is you go back and still diurese them. You go back and still give them furosemide and pull back the fluid. But you don't really want to jump to the inotropes just like that. You understand? Try to see if they respond to a small amount of fluid, and then you just give them that medication to pull back the fluids out. All right, leg elevation, but that's, yeah, you still encourage your leg elevation, but your fluids, you still can give them the fluids, and then definitely, you know, but you're not going to give them like running 1 liter of fluid and drown them. You understand? You're just going to give them a small amount of fluids, and then from there, usually they will respond. So once you realize that the fluid is, you know, pushing their blood pressure in a correct direction, then it's okay. But you don't want to be giving them like, say, 500 mils. You start with probably like 100, 250, the max, or depending on the doctor's order. And then you will go ahead, well, yeah, depending on the doctor's order, but you don't want to be giving them too much, like over like 250, because you'll be drowning that patient. So you go ahead and still give them their little fluids, and still go ahead and give them their high dose furosemide and pull it back down. You understand? Pull that fluid out and just monitor the patient, especially if the patient is talking. You know, the patient is, even though patient blood pressure is low, the patient is not like in respiratory distress or anything like that, where you're thinking that, oh, if I give them 100 mils, you know, so depending on your assessment of the patient as well. All right. ICU monitoring, definitely. And that patient, you will make sure you get your 2 IVs. All right. Make sure you get your 2 IVs, because as someone had said, you know, you're anticipating inotrope. So this patient is critical. So you always want to go ahead and start off with your 2 IVs if you can. All right. So we definitely will do the loop diuretic because it reduces the fluid overload and the pulmonary edema. All right. A client with pneumonia is on IV antibiotics. Which finding shows improvement? The white blood cell count decreases, persistent fever, oxygen saturation of 85%, or the crackles in both lungs. If the patient is having pneumonia and you have been giving them the IV antibiotics, which would show that the patient is having improvement in their infection? Is it the white blood cell count decreases, persistent fever, oxygen saturation of 85%, or crackles in both lungs? The white blood cell, okay, nice. Okay, yeah, the white blood cell. What's the normal range you're looking for the white blood cell? Fever, So if they're having fever, it shows that, you know, the infection, the number is still high. So the fever is saying that it's getting worse. 8 to 10. Do we have anybody else within the normal range we're looking for your white blood cell count? 5,000 to 10,000. Yes. All right. So the white blood cell count should decrease if they're improving with the antibiotics that you're giving them. If you realize that it is like, you know, over 10,000, then that's a problem. All right. It's going in the opposite direction. But if you realize it started out at 22,000 and you're trending down, then, you know, that's a good sign. All right, so you keep monitoring that. The fever is the same thing. The fever, you might have the fever even if it is, you know, trending down, but you don't want to be trending up with your fever. All right, with your numbers. So what's the correct answer for the range? The 5,000 to the 10,000. All right. Yeah. All right, so definitely the white blood cell count would say that it is improving. All right, crackles in both lungs. If the patient is having crackles in both lungs, what are you suspecting? So you have this patient that is having pneumonia, and now you're listening and you realize that in both lungs there is like just so much fluids there. What are you thinking for this patient? Would you be concerned about the crackles in the lungs? Overload, yes. So probably while we were managing or while we were treating the pneumonia or the sepsis from that pneumonia, we overload the patient with fluids. So now we're going to have to take it back. You understand? So we're going to have to go back to our poor perfusion. I'm not thinking along that line. Now you'd have to go back to getting that fluid out. So you're not going to have to go back to your furosemide, your loop diuretic, to pull that fluid out of that lungs. You understand? So definitely you want to do that. All right. The oxygen saturation 85%. Would you be concerned about that? And this is on room air. Yes, yeah. So the oxygen saturation is low. The patient is having pneumonia. Definitely, you'll be concerned about that. Sometimes, depending on the severity of the pneumonia as well, you know, you will have your low, you'll tend to have like, you know, decrease in your oxygen level. So definitely put your patient on a little oxygen. Make sure that it's improving, and then from there. All right. A client with cirrhosis has confusion and is lethargic. Which lab value is most concerning for that patient? Is it the ALT, which is one of the liver, you know, one of the liver parameters, one of the liver, what do you call it again? Enzymes. All right. Is it the ALT? Is it ammonia? Is it the bilirubin? Or is it the hemoglobin? So you have a patient with cirrhosis and the patient is confused. The patient is also lethargic. Which lab value is most important for that patient? So we see ammonia here, ammonia. Do we have anybody else with another answer? Ammonia, Kai says ammonia. So definitely, how am I send this thing to my moderator? Well, Fire, you're here. Thank you for tuning in. So definitely your ammonia is something that you'll be concerned about. All right, and when you're thinking about ammonia, what condition are you thinking about with a patient having confusion and very lethargic? What are you thinking about? Cirrhosis. I'm thinking about something else. Encephalopathy. Yes. All right. Liver failure. But if the I'm thinking along the line of encephalopathy. So that patient is, you know, have cirrhosis of the liver. So they're now confused and they're lethargic. You're thinking about something up here. You understand? They're having encephalopathy because now the ammonia level is going to be a little bit higher. All right. So you want to make sure that you're looking out for that. For bilirubin, Who would you be concerned about for with elevated bilirubin levels? The baby. Okay, what condition are we thinking about? Gallbladder, liver, jaundice. Yes. All right. Yes. So for the babies, we're thinking about the jaundice. All right. Liver, jaundice. Yes. All right. So if you have a baby that is born, so if you have a newborn baby that is jaundice, what is one way that, you can promote or encourage the mother to get, this mother just had C-section and the baby look a little bit, jaundice, not to the point where you have to take the baby out into the sunlight, but yes, you need the light. But, the mother is there and there's a lot of breast milk and everything. What is one way that, you help with getting some of that color from the baby? So the mother is there. Mother can't get out of bed right now, but the baby is there. Baby hungry. Definitely encourage them to put them on the breast, the breast, because that is going to help with pulling some of that bilirubin level. So you'll tend to have them passing their stool, help with promoting, them passing their stool and getting rid of some of that bilirubin as well. All right, but yes, the sunlight is gonna be one, and the regular light, that blue light is the other one. But if you see the answer with the baby and the breast milk, definitely go ahead and encourage your mother to start breastfeeding to help with, getting rid of some of that bilirubin. All right. All right. A client finding requires immediate intervention or after catheter. Which client finding requires immediate intervention after cardiac catheterization? So I have a patient that just came out of the cath lab. All right, but then the patient is having small bruising at the insertion site. The patient is also reporting chest pain. The blood pressure is 118/72 and the heart rate is 80. Which finding requires you to go ahead and report or start doing something immediately for that patient? Is it the bruising that you're concerned about? Is it the chest pain that the patient is having, the blood pressure 118/72, or the heart rate of 80? Which one would you be concerned about? The chest pain. Okay. Chest pain. Someone says small bruising at the insertion site. Okay, bruising. All right. Why are we concerned about the bruising though for this patient that came out? So you have the patient just coming from cath lab. All right. So we changed to chest pain. So the patient just came out of cath lab, but the patient is having a small bruising. There is also some chest pain. The blood pressure is 118/72 and the heart rate is 80 over 80. So possible bleeding. Yeah, the patient is gonna have bleeding. Remember, the patient just come from cath lab, so that's one thing we'll be monitoring for. All right, so we're not gonna be surprised that there is a little bit of blood. So definitely you will be checking for chest pain. All right, let me ask over to this side. I saw Kai says it, but why are you concerned about the chest pain? The patient just came out of cath lab. Why are you concerned about the chest pain? Patient just had cardiac catheterization, so the doctor going there and mess around with the heart, so the patient is gonna have chest pain. So why are you concerned? Possible bleeding. Let me see. Why are you concerned about the chest pain? Embolism, yes. So the thing you're concerned about is a PE. All right, clots. So they just went in, mess around with the heart. You don't want a patient to be having chest pain because more than likely the patient is throwing a clot. I did saw your answer, Kai, but I just wanted to hear what they're saying. Yes, all right. So the patient might just be throwing a clot. So you want to make sure that, you go over and evaluate, let the provider know so they can know what they're going to be doing next. All right. So you don't want it to be a case where after that surgery, they're having any form of PE or any occlusion going on. The small bruising at the insertion site, is probably expected. All right, it is expected. Depending on the size of it, you'll just monitor it, and then from there, blood pressure 118/72 is pretty good blood pressure. Heart rate of 8 is pretty decent. So, you know, don't need to be worried about those. But if the patient starts having chest pain, definitely, you know, you want to call back the team and let them know this is what is happening. Probably they'll start, you know, some blood thinners, whatever it is. Just let the provider know so they can always go ahead and start something. All right. The nurse cares for a client with peritoneal is good. The nurse cares for a client with peritoneal dialysis. Which finding is most concerning? And even if you don't know, you know, hi DeRay. Even if you don't know the answer, as I say, always just look at the answers and see which of them is concerning for you. If you see this, you know, if you had this, would it be concerning for you as a patient or, you know, as a nurse? Just think of it. So the nurse cares for a client with peritoneal dialysis. Which finding is most concerning? Is it clear yellow drainage? Is it abdominal cramping? Cloudy drainage? I'm echoing. My microphone is off. Are you, well, let's see what's happening here. I think the battery dead. Oh no, hold on. All right. Mona, welcome. All right, hearing me a little bit better? All right, so the nurse is caring for a client with peritoneal dialysis. Which finding is most concerning for the nurse? Is it the clear yellow drainage? Is it the abdominal cramping, cloudy drainage, or weight loss? So which finding is concerning for you? Is it the clear yellow drainage, abdominal cramping, cloudy drainage, or the weight loss? So we have Shanna says cloudy. Yes. Do we have anybody else? Someone says A, yellow drainage. We have a C, cloudy drainage. I would say cloudy drainage. Cloudy, yes. So the one that is cloudy, what you're thinking about? If you see a cloudy drainage coming from the peritoneal dialysis, what are you concerned about? Infection, yes. All right, so blood. Okay. All right, so definitely you want it to be yellow. All right, peritonitis, definitely you'll be concerned about. All right, so definitely that is concerning. All right, so cloudy drainage, peritonitis is what you'll be concerned about with that patient that is on dialysis. Abdominal cramping, would you be concerned about the abdominal cramping? Yeah, not really. Okay. It depends on, depends on where the cramping is as well, but it might be expected if they are having peritonitis. All right. The weight loss, that's something that will take a few days, weeks before they start having. Yellow drainage, are you concerned about the yellow drainage, or the yellow drainage is normal finding? Normal, yes. All right, so the one that you'll be concerned about is anything that is cloudy. All right, just always think about infection, white blood cell, white cloud. All right. Which symptom is expected for a client with hypoglycemia? Is it flushed skin, tremors and sweating, slowed heart rate, fruity breath odor? So flushed skin, tremors and sweating, slow heart rate, fruity breath odor. The sweating, okay. Do we have anybody else with another answer? Tremors, clammy. Okay. All right. Yes. So the tremors and the sweating is something that is expected for hypoglycemia. You still can have the flushed symptom, skin, the slowed heart rate, you know, but in terms of what is the fruity is with hyper, fruity is with okay, but which one exactly we're talking about with the fruity? If you have the fruit, somebody come over and they're talking to you, or you go over to your patient and the patient is diabetic and they have the fruity, the fruity breath smell, what you're thinking about? It is very characteristic of hyper. Okay, but how hyper? DKA, yes. DKA, diabetic ketoacidosis, ketones, yes. All right, so if you go over and the patients, you know, have that fruity breath smell, then definitely you're thinking about your DKA. All right, it's a classic symptom of DKA or sign. All right, the slowed heart rate, they'll have it. But as I said, the expected finding is that they're going to have the tremors, you know, the sweating, which is usually characteristic of that. All right. A nurse is caring for a client with a chest tube. Oh, I did this one. All right. A nurse cares for a client with increased intracranial pressure. All right. Which intervention is most appropriate? So you have a patient that has increased intracranial pressure. Which intervention is most appropriate for that patient? Are you going to place the patient in a supine position? Keep the head of the bed midline and elevate at 30 degrees angle. Suction every 30 minutes routinely. Or give hypotonic IV fluids. So you have this patient that has increased intracranial. 6602. I'm so sure what you're talking about. Sorry, what was this? So you have placed the patient in a supine position. Keep the head midline and elevate the head of the bed to 30 degrees. Give hypotonic IV fluids and suction every 30 minutes routinely. So we have. You're tired. Keep the head elevated. Okay. Midline. Keep head elevated. I'm out. All right. No problem. Not a problem. Thank you so much for tuning in. And come back next time. All right. Do really appreciate you taking the time out. All right. So keeping the head midline. Definitely. And elevate it at 30 degrees angle. Yes. Oh, remember to subscribe as well. All right. And why do we keep them in that that position though? Midline can't be too high with pressure. Yes. So that's why you're going to be the 30 degrees. All right. So semifolars, other answers will increase. Yes, the other answers will increase your intracranial pressure. So definitely you don't want that to be happening. So placing them in supine position is a no-no. You want them like, you know, 30 degrees angle. Suction every 30 minutes routinely. Give hypotonic IV fluids. All right, so the head of the bed is the most appropriate position for the patient. All right. So if you have this patient, what medication would you be anticipating? So you have a patient that has increased intracranial pressure. What medication you're anticipating for this patient? So the patient is so symptomatic, you know, the pressure is high. What are you thinking about for that patient? So it's a diuretic you're thinking about. But what form of diuretic? Or what class of diuretic you're thinking about? Osmotic, yes. All right. So you want to think about your osmotic diuretic. So your mannitol, definitely you want to keep that close by, or you want to try to figure out where that is. So you can go ahead and get that started on your patient. All right. So your osmotic diuretic is what you'll use for your increased intracranial pressure patients. And one of the medication is your mannitol. All right. All right. Which client is most at risk for pulmonary embolism? Is it the post-op client on bed rest? Is it the client with the asthma using inhaler? Is it client with pneumonia on antibiotics, or the COPD are using oxygen? So who is at risk here for PE, pulmonary embolism? A, okay. So Nicia says A, the post-op client on. Okay, yes, the post-op client. Post-op, definitely. That patient is at risk for PE. What are some of the other risk factors for pulmonary embolism? Or for an embolism? Cupids, osmotic diuretic. Yeah, the lack of movement. They have this thing for pink frothy sputum. Pink frothy sputum is related to, oh, for the PE you're talking. Okay. Mm-hmm. They have the different, they have, okay, so your patients that are on like your contraceptives, definitely your estrogen levels, yes. Do we have anything else? So prolonged inactivity, such as your bed rest, your long distance, travel, obesity, smoking, and you have like a cancer diagnosis, chronic kidney disease, diabetes. I think I was thinking about, they have some, like a mnemonic. I don't remember if I'm thinking about it correctly. Poor circulation, yes. Long travels, definitely. So anything like that. All right. But for your patients who are post-op, you want to be thinking about, your PEs whenever they start, complaining of like chest pain. They're feeling, they're having chest pain. They start having shortness of breath, sudden onset shortness of breath. Their oxygen level is like getting low. Sometimes when they reposition, the oxygen level still is low. So things like those, you have to keep in the back of your mind that, okay, then these are some of the signs and the symptoms for PE. So you want to keep that patient, monitoring going. All right. And where am I now? A client, which finding in a newborn requires immediate report? Put on compression socks. Yes, yes. Which finding in a newborn requires immediate report? All right. Is it irregular respiratory rate? So the respiration is like 40 breaths per minute. You have acrocyanosis of the hands and the feet, nasal flaring and grunting, or the Moro reflex present. Which of them is concerning? Is it that is something that you would report immediately? Irregular respirations, 40 breaths per minute, acrocyanosis of the hands and the feet, nasal flaring and grunting, or Moro reflex present. So Avmi says 3. Okay, so 3 is the nasal flaring and grunting. Do we have anybody else? Marvia says C. Okay. Nasal. Okay. So definitely yes. For that one, why not the irregular respiratory rate of 40 though? Would you be concerned about a respiratory rate of 40, 45, 50, 55, 60 in a newborn? 45. That normal, yes. All right. So no, we're not concerned about that respiratory rate. What about acrocyanosis? What's acrocyanosis? Is that something that is normal for them? When you have like the bluish discoloration of the hands and the feet in the newborn? That's normal, yes. All right. Nasal flare, the more reflex present. The more reflex, which one is that one again? Is it when they go? Is that one? Let's look it up. More reflex, which one is that? Or when you do something like this. I'm not a peds person, so let's look up that one. So the motor reflex. So yeah, the motor reflex is this one. All right. Flaring, I think. Okay. So the motor reflex is the one like when they come out and they just look frightened. Yeah, that's normal. All right. So they have the startling look. So the one that would be concerning is the grunting and the nasal flaring, because that would mean that what's going on. If they're flaring, baby's heart rate are usually high, definitely. Okay. But if they're having nasal flaring and they're grunting, what are you thinking? Blood sugar, respiratory. So yeah, you're thinking respiratory. They're having respiratory distress. All right. So anytime you know the child comes in and they're grunting, yeah, man, the grunting is not no normal grunting. All right. So always check that out. And the nasal flaring is because they're having respiratory distress. So you always want to make sure that you evaluate that patient. Check the oxygen saturation. You know, check if depending on the age of the child as well. You know, can open the mouth and check. Do all of the different checks, but it means that they're distressed. Look at their rib cage. Look at how they're breathing. You know, if they're having like those recession, intercostal retractions, things like that. The drug addict moms, yes, definitely. Sometimes the babies will be born and they'll start having those kind of is after the drug addict. So when the mothers, the babies are born, usually they come out and they have the what do I call it? The addiction. What do I call that thing? When the babies are born. Oh, let me look up that one. The child addicts, babies, newborn. Let me look it up. Symptoms. Yes. Oh, the overreactive reflexes. Okay, yeah. So their reflexes are usually overreactive. Difficulty breathing can also be a symptom. All right, but that's and usually they're very fussy, miserable, because them a withdraw. You understand? I don't know the name, but I know what you're talking. Yes. So usually when they come out, they're going through withdrawal. Because you take them from the source. You understand? You take them from the source and you put them over that side. No, they don't have anybody feeding them again. You understand? So all of that blood supply that was going to them, after a while, it starts wearing off in their circulation. And so they start get so fussy. They get miserable. You understand? So they tend to have that. But for this baby, definitely the retractions, you always want to be looking at the retractions, the grunting, the the nasal flaring. Those are things that you can tell when a child is actually distressed. So when you're examining them, you're talking to mother, just lift up them clothes, you understand? And just be counting their respiratory rate for the 1 full minute. Count their respiratory rate for the 1 full minute, and also look at how they're breathing. All right, and the best way, as I say, when you're doing that is just lift up their clothing, and while you're talking, you'll see sometimes they're even sucking on the breast, and you can see whether or not they're distressed. You're looking at their nose, and it's flaring. You're looking at how they're breathing, how their rib cage is. Is it like, sunken in for each breath? Then definitely you'll be able to see. My cousin adopted twin from a drug addiction mom, and one was like that. The other was super smart. Okay, nice. All right. So that was that one. All right. A nurse assesses a client with thyroid storm, which is priority for this patient. Monitoring the temperature, checking the glucose, assessing peripheral pulses, and monitor urine output. So you have a patient that is going through thyroid storm, which is priority for the nurse. Is it monitoring the temperature, checking the blood glucose, assessing the peripheral pulses, or monitor your urine output? Thank you for the rose, Luminous. The temperature, okay, okay. Thank you for the follow, relax and comfort. Temperature, Nisia. All right. Simona, the temperature. Why do we say that the temperature? What are we concerned about? Or why, why the temperature you're more concerned about with a patient with thyroid storm? Not a problem. The crisis, okay. All right, so when you have the thyroid problem, when you have the thyroid storm, what is happening with your metabolic rate as well? It's firing. All right, so you want to make sure you're checking your patient's temperature because of the hyperthermia that is from the thyroid storm. So definitely you want to manage that or monitor that because that is very life-threatening for those patients. All right. Check blood glucose, assess peripheral pulses, monitor urine output. Well, the priority there would have been the temperature. Definitely you want to go ahead and check your pulses because you don't want the patient to be tucking away on this one. The heart rate is just so, they're going through this thyroid storm and their heart rate is high. So definitely, look at their temperature, then look at their heart rate, and then from there. All right. So hyperthermia from thyroid storm can be life-threatening. So you want to make sure that you're addressing that and monitoring it. Hypothalamus is overacting, yes. Or the thyroid gland. Yes. All right, so definitely you want to go ahead and watch for that. All right. A pregnant client is at 36 weeks, reports severe right upper quadrant pain and headache. All right. What is the nurse's priority? So you have a pregnant patient that comes in and they're having right upper quadrant pain and headache. What is it that you're concerned about? For this patient? Check the blood pressure, liver, okay. All right, okay. Preeclampsia, definitely. All right, so what's the nurse's priority? Obtain the urine sample, assess the blood pressure, place the client on bed rest, or notify dietary. Queen Anash, welcome, welcome. So the patient is 36 weeks, pregnant, reporting right upper quadrant pain and headache. What is the nurse's priority? Obtaining the urine sample, assessing the blood pressure, place the client on the bed rest, and notify the dietary department. So Marva says preeclampsia. Shells is saying place the client on bed rest. Okay, preeclampsia. Okay. So definitely you're concerned about preeclampsia, eclampsia. All right. So looking for potassium, bed rest, BP. Okay. So definitely the priority there is going to be the blood pressure. Remember, the patient is pregnant. The patient is also having headache. All right. Protein, definitely. So you're concerned about, eclampsia, preeclampsia. All right, so bed rest might be, yes, you're going to put the patient on, you're going to let them rest. But I don't think you're going to put them on strict bed rest at that time, If she was just having the severe right upper quadrant pain but no headache, what would we be concerned about? So the patient is having the abdominal pain, is still pregnant, and there's no headache. Would you be concerned about anything specific? Hemorrhage. Why hemorrhage though? Constipation. Okay. Why hemorrhage though? Hold on 1 minute, please. All right, sorry about that. All right. So, okay, so, oh, you were in that position with the hemorrhage? Okay, okay. All right. Ectopic. Would you be concerned about ectopic at 36 weeks though, Marvia? That doctor who is, unless you probably... no? Okay. All right. No, so that would be a big no for the one day. Wouldn't be concerned about the ectopic at 36 weeks there. All right, but remember what organs are up this side. You know, you'll be thinking about like your liver. Okay, okay. You'll be thinking about your liver up that side. So you can always be thinking about, yes. So definitely, if it was like right lower, then you'll be concerned about your, you'll be thinking about like your gallbladder, probably your liver as well. You know, so depending on what, you'll be thinking about like your appendix and all. Alright, but with the headache, you're more concerned about your eclampsia. Alright, you're thinking about the blood pressure being high. You're thinking about probably protein in the urine, things like those. Alright, for that 36 weeks old pregnant lady. Alright, so where was my question? I think it was further down. I thought about that. Yes. All right, so definitely, let me go back to that question. Oh, where's my question? So what's the nurse's priority? So assess the blood pressure. All right, that would have been the answer. All right, placing the client on bed rest would have been okay. But complete bed rest, I don't think so at this stage, 36 weeks. Notified dietary, I don't see that as being important. Obtaining urine sample, definitely you want that to look at their protein level. All right, and then depending on what the urine is showing, the blood pressure reading, then you can know whether or not this patient is like, eclamptic or preeclampsia candidate. All right, but the blood pressure is going to be very, very important here for this patient, especially with the patient having the headaches. All right. So for example, now you have the patient and the patient has the protein in the urine, the blood pressure is high, and then you notice you're talking to the patient starts seizing. What are you going to be doing? So the patient starts having seizures when you're examining or you're talking with the patient. What are you thinking about now that the patient having the seizure? So you just did the urine and you realize that there's protein. You also realize that the blood pressure is a little bit elevated and the patient is still 36 weeks pregnant. What are you thinking? Preeclampsia. Do we have anybody else thinking anything else? Proclamation. Do we have anybody else thinking anything else? I think you're thinking preeclampsia as well. Reading between the lines. Patient cannot leave. Have to have the baby. Get out. Definitely. But what the condition are we thinking about? Are we going to be like, what are we going to be doing at that time? So the patient is seizing 36 weeks. You just got the protein in the urine. Blood pressure is like 140s, over 90s. And you're there. Are you going to be getting some dilantin and say, you know, just hang that and, you know, have the patient just run the little time? Okay, so we're going to go ahead and do the C-section. All right, what else are we going to be doing? Why are we doing Are we at pre-eclampsia now? Or are we at the eclampsia phase? Is the patient eclamptic or pre-eclamptic? Because now the patient is actively seizing. So eclampsia, yes. So the patient is now eclamptic. The pre-eclampsia would have been, you realize that the protein is there, but the patient and the blood pressure is high, but the patient hasn't gotten any seizure. All right, but now that she's having seizure, she's not no pre anymore. She is eclamptic. All right, so definitely, you would go ahead and prep that patient to get out that baby. In the meantime, the patient is having seizure. What medication you're anticipating for that pregnant mother? So the patient is seizing there, and the doctor is saying, let's get the patient to, you know, the OR. What are you thinking about in terms of medication? Are we going to be getting some dilantin? Are we going to be getting some Keppra? What medication are you anticipating for your pregnant woman? Anticonvulsant, definitely, but what medication are you going to be grabbing? Are you going to be grabbing heparin? Are you going to be grabbing magnesium? Are you going to be grabbing Keppra? Are you going to be grabbing morphine after the baby come out? Okay, but the doctor is taking a while to come, so the doctor is taking a little while to come, but in the meantime the doctor says go ahead and prep the patient, grab the medication for is it mag? Definitely it is magnesium sulfate. All right, definitely it's going to be magnesium sulfate for your pregnancy patient, your eclampsia patient, eclamptic patient, because that is also going to help with dilation. All right, slows down the dilation and everything. So definitely the contraction, it's going to help with the contraction, so it's going to help with slowing down the contraction and help with dilation, relax the muscle. All right, so you definitely want to go ahead and start grabbing your magnesium sulfate and start getting that hooked up. Are you going to be running it at, like, you know, your 1 drip per, are you going to be running over 2 hours, or how fast are you going to be running it, anticipating it going in? Is it going to be like your, who was saying that we're going to do the IM potassium and the IV, are we going to be doing IV or the IM? Are we going to be doing fast? You know, is it going to be infused fast or slow? So you're going to run it in fast. All right. Oxytocin 2. You really, at this time? No, I'm not in the oxytocin. No, the oxytocin wouldn't be for now, dear. In the middle of, oh, okay. So you're gonna run it in. It's gonna be running real fast. So usually you try to get it in within like the 15 minutes thereabout. All right, because remember that is what is gonna help with breaking that seizure. All right, so definitely you wanna run it in real fast. So usually sometimes they'll put it on the pump and whatever, but sometimes they might not have time to be putting magnesium on the pump. So you run it in fast over, like, you know, 15 minutes to get that going, and then they'll do the maintenance. Okay, no, you're good. All right, so definitely your magnesium, you want to think about that. Always have it when you see a patient come in. Definitely always think about your magnesium, because you're thinking about the eclampsia phase. Patient seizing, get the patient prep, get the magnesium going to the OR, and then from there, once you take out the baby, usually that kind of correct in terms of the seizure. All right, but you still want to go ahead and monitor the mother afterwards as well. All right. Patient can seize. Yes, the patient can still seize after. All right. Would that be used in an ordinary situation? The magnesium, if the patient wasn't pregnant, If the patient wasn't pregnant, good night, Marvia, good night. If the patient wasn't pregnant, then you would go ahead and still use your regular, like, you know, your regular anticonvulsant medication. All right, you'd go and use your regular anticonvulsant medication. So depending on whatever is, you know, they're using in your facility or what they order, then definitely you'll go ahead and with that. So whether or not it is like Keppra, whether or not it is like phenytoin, you know, the dilantin, whatever it is, then definitely, yes, definitely you'll go ahead and, you know, administer it. But the magnesium is pretty safe in pregnancy. And it also helps with the contraction as well, you know, so definitely Adivand. Okay, yeah, so like for your babies and all, you can use that, the rectal. Sometimes they do it rectally for the babies. Yes. So anything else that will go ahead and break the seizure during that time, you'll go ahead and use it. All right, and then from there. All right. A nurse is caring for a client. A nurse is caring for a client with alcohol withdrawal. Which symptom is most concerning? Oh, your phenobarbital. Okay, yes. You can also use phenobarbital for your seizure as well. All right. Yes, you can. You can, Mona. A nurse is caring for a client with alcohol withdrawal. Which symptom is most concerning for you as the nurse with the patient? Is it tremors? Is it diaphoresis, hallucinations, or nausea? So you have a patient that is going through withdrawal, all right, from alcohol. Which symptom is most concerning for you? Is it the tremors? Is it the diaphoresis, the hallucinations, or the nausea? Ria, welcome, welcome, welcome. So this patient is having alcohol withdrawal. All of them, okay. All right. So all of them you'd be concerned about. All right. But if you were supposed to address one of them, which one of them would you run to first in terms of addressing? Is it the tremors, the diaphoresis, hallucinations, or the nausea? The diaphoresis, okay. Nausea, okay. One more, let's see. Tremors. Okay, so what about the hallucination? What if the patient start climbing on the wall? What if the person, you know, start talking? Could be tremors, okay. But what, all right, so could be tremors. All right, so we see patients with tremors a lot of times. Is there anything that is like significant when I have a patient with tremors? Central nervous system issues. Okay, okay. Temperature, okay. So a lot of times when you think about your DTs, you remember your DTs in alcohol withdrawal? When your patient starts acting delirious, is that something that you're usually concerned about? So when the patient starts hallucinate, sudden onset, is that something that you're concerned about? Because nausea, a lot of times you might have a patient with nausea and, you know, yes, you want to address it, but delirium, yes. So your DTs, the delirium tremens is something that is concerning for a patient that is having alcohol withdrawal and having hallucinations. So you definitely want to address that. Tremors, a lot of times you have tremors. I've never really seen tremors kill nobody. You understand? Never really see tremors kill anybody yet. So I would kind of hold off on that one. That wouldn't be like, say, priority for me. The diaphoresis, you know, the sweating wouldn't be that much of a priority for me as well. The nausea, I've never seen nausea kill anybody as yet. Yeah, I understand. Not saying that we're waiting for it, but out of everything here, if I see somebody that is hallucinating, I would be very concerned about that. You understand? The others, you'll address them, but definitely you'll want to go ahead and address your hallucinations. All right, but your delirium tremens is something that is very, very important when you're thinking about your alcohol withdrawal or your withdrawal symptoms. It's always an emergency, so you definitely need to address that. All right. The others are pretty. When a patient is going through alcohol withdrawal, a lot of times they might have the tremors, they might have the nausea, the vomiting, and by the next day or two, they're good. You understand? They survive, but definitely you want to look at the answers that you have here and see which one of them is life-threatening. So the one that is the correct one is the hallucinations. All right. That is going to be the one that is most concerning. All right. All right. You're good, Mona. All right. So which intervention is best for a client having panic attack? Teaching the client relaxation techniques, staying with the client in a calm environment, providing detailed explanations, and encourage decision making. So you have a patient that is having panic attack. Which one is the best intervention for you and that patient, for that patient at that time? Is it teaching the patient relaxation techniques, staying with the client in a calm environment, providing detailed explanations, or encourage decision making? Stay with the client, okay. Do we have anybody else? And why do we want to relax and stay with the client? Yes, you don't want any in a quiet environment because you don't want anything that is going to be stimulating and causing, the patient to have worsening panic attacks. So definitely get them into a quiet room, and that will kind of help with, them breathing a little bit better. You can encourage them to breathe a little bit better and just talk them through it. All right, but definitely that would have been the best answer there for that patient. You wouldn't want them to be providing any details, explaining anything right now because, when they're there having their panic attack and they're trying to explain what is going on, it's just worsening it. You understand? And especially when they can't say exactly how they feel. Yeah, you don't want to be around them at that time because you're not going to get anything out of them. All right? Encourage decision making. At that time, it's not the best time to try to, have them to come up with some decision. So get them in anywhere that is, has low stimulation, it's quiet, and from there, you can work your way through, other things. All right. And you guys can tell me whenever you guys are ready to go, because I'm not working tomorrow. All right, so what time is it? 10 o'clock. Whenever you guys are ready, you guys can, start tapping out. All right. When my eyes are ready, I will be tapping out, and you will see me do something like this. Yeah, my eyes are closing down. All right. A client develops chest pain that is unrelieved by nitroglycerin. What's the nurse's priority? So you're in the hospital, you already gave the patient some nitroglycerin tablet, and the patient is still having pain. What is the nurse's priority? All right. Obtaining vital signs, administer oxygen, notify the provider, or prepare for discharge. So the patient is having chest pain and you give one nitroglycerin, and the patient is still having the chest pain, you give another one. The patient is still having the chest pain and you give a third one, and the chest pain is still there. What are you going to be doing for that patient? A, obtain vital signs. Notifying the MD. Okay. What else are we going to be doing? I need one more answer. Somebody just type something. A, B, C, or D. Vitals, headache. All right. So you've given the nitroglycerin and the patient is still having the chest pain. What is the nurse's priority? Obtaining vital signs, administer oxygen, notify the provider, or prepare for discharge. So you remember, so you give the nitroglycerin, the expectation is that you're going to be relieved of your pain, right? No, Mona, you're at the hospital. You're at the hospital. Remember, you're the nurse at the bedside. All right, so you can't call 911. All right, so you're notifying the doctor. Let's go. You notify the doctor, but yet still the patient is still there. The doctor is putting in order. What can you do in the meantime? Remember, when you're thinking about chest pain, what are you thinking about? You remember the Mona? Your morphine, oxygen, nitroglycerin, aspirin. You remember that mnemonic? So what can you do from that? You already did your nitroglycerin. What else can you do in the meantime? So the patient is having the chest pain. Usually you give the nitroglycerin. You're anticipating that the patient's chest pain is going to be, going away because you have those vessels that are dilating. So you have the flow of the blood going in. So you're going to be free, or at least the pain is going to move from a 10 to a 2 because the medication is actually doing what it's supposed to be doing. All right. So you give the nitroglycerin. They're still having the pain. Just go ahead and put on the little oxygen to make sure that wherever the occlusion is, because obviously there is some occlusion taking place there, that the nitroglycerin is not able to open up that vessel to allow for the blood flow to go in. So you're going to have your ischemia taking place there. So you want to go ahead now and make sure you're giving your patient the oxygen to help with perfusing that little area to prevent further ischemia from taking place. So you're going to put on your oxygen. In the meantime, you'll run and tell your doctor, you do everything else. But remember your Mona, your morphine, you'll get it from your doctor's order. You can always go ahead and start your oxygen. You already gave your nitroglycerin, it's not working. So obviously we're thinking about something else. All right, and then your aspirin as well to help with those platelets. So definitely you want to start your oxygen. All right, and then from there, so you'll notify your provider. Obtaining vitals. I know somebody had said obtaining vitals. What are we looking for with the vitals? What are you looking for with the vitals? So you give them the nitroglycerin. You're expecting that their blood pressure to be tanking, So they'll be having, it's going to increase. So the blood pressure is going to decrease. Because remember, the nitroglycerin is a vasodilator, so it's going to drop your blood pressure. And then I saw somebody had said the headache. That's how you're going to get the headache as well. All right, because you're dropping the blood pressure suddenly. The sudden drop in the blood pressure, a lot of persons tend to have that lingering headache with it. All right. So you'll administer your oxygen. You'll notify your provider. You won't prepare this patient for discharge. You'll prepare this patient for admission. All right. So the oxygen is the first step in the ACS protocol. So definitely use it. That is your priority. Remember, you're thinking safety first. All right. So definitely do that. Increase heart rate. I think probably, I don't know if it's going to increase the heart rate. I don't think it's going to increase the heart rate. I don't think there is going to be significant, changes with the heart rate. It might drop a little bit, but I don't think it's going to be significant. It's the blood pressure that is going to be significantly affected. All right. So if you've given the 3 liters of the oxygen, not the 3 liters of the oxygen, if you've given the 3 tablets, the nitroglycerin tablets, and you realize that they still haven't gotten any improvement in the pain, you've started your oxygen and you call the doctor and the doctor says, okay, go ahead and administer the medication. What medication are you anticipating and why? Welcome, welcome. So it's the same Mona. Your morphine, oxygen, nitroglycerin, and your aspirin. That is always the 4 things that, you know, you're anticipating. All right, so you're going to be anticipating your morphine. All right, so that will help with also their breathing. So sometimes if you're having the chest pain and, you know, they are panicking or they're hyperventilating, things like that, it will also help with their respiratory rate as well. So you'll be helping their pain as well as, you know, making them feel a little bit more relaxed as well. All right. So you can anticipate your morphine there. A client with a stroke has right-sided weakness and slurred speech. Which intervention is priority? So this patient has a stroke and has right-sided weakness and slurred speech. Which is priority for the patient? Which intervention is priority for you? Perform range of motion exercises. Place the client on NPO, as in nothing per order or mouth. Per mouth. Provide emotional support or encourage ambulation. So you have a patient who has a stroke and has right-sided weakness and slurred speech. Which intervention is priority for you at that time? Is it perform range of motion exercises, place the client NPO, provide emotional support, or encourage ambulation? Thank you guys for tuning in. C, emotional support, NPO. C, provide emotional support, NPO. Okay. Definitely you want to keep that patient NPO. Let's go back to it. So remember, the patient has a stroke. The patient face, you know, you have that drooping, the weakness there. The patient also has slurred speech. So which intervention is priority? You're going to have the relative. Mona says ambulation. How is that patient going to ambulate now? That patient is going to ambulate and have, like, you know, dragging. If the patient can ambulate, that is, you know, you're going to have to assist that patient because remember, one side is weak. So that patient is going to be a high fall risk patient if you try to have that patient walking. All right, so that is not priority for, you know, priority. You're not interested. We're not interested in the patient ambulating at this time. All right, emotional support we definitely want to give, but that is not even priority right now. We're thinking about the fact that the relative is going to walk through the door and they have their big water burger with a juice and say, oh, this is for grandma and this is for grandpa, and going over there to feed the patient. All right, you're thinking about choking, you know, the risk for choking, aspiration. So you definitely want to keep that patient NPO. And then from there, you can do everything else that you're supposed to be doing. So making sure that you do those different testing, you know, keep the patient NPO if you're going to try to get a swallow test done if they're able to do so. But if the patient has the slurred speech, definitely you keep that patient NPO, nothing by mouth. All right. Provide emotional support. As I say, you're still going to do that for all your patients. Performing range of motion exercises. That's not really a priority for this patient right now. As I say, you're always thinking about safety first for the patient, and always choose the answer that is talking regarding safety for your patient. All right. So the one that is most important here is to place the client on an NPO list or NPO. All right. So aspiration risk must be ruled out before oral intake. So say for example, you have the patient, the same patient is a stroke patient, and you've already done the swallow test on this patient, and you realize that the patient can, you know, you can feed the patient. So let's say the patient is stable. Would you give that patient, assign that patient to like your LPN to go ahead and feed the patient? We had a question like this the other day, so I want to just ask. Would you go ahead and have an LPN feed this patient, or you would go ahead and do the feeding for this patient? Nope. Okay. So the patient passed the swallow test. Would you go ahead and have the LPN feed the patient? Yes. Okay. Yes. So the patient is pretty much stable. So even though the patient might have, you know, the RN patient, not stable. Okay. So even though, you know, the patient might have the slur and the patient might have the weakness, as long as you've done your evaluation and you realize that the patient can swallow, So you as a RN has done that exam and you realize that the patient is able to swallow without choking, coughing, things like that, and the patient is stable, then it's okay to delegate that duty to your LPN to assist with feeding. All right. But if the patient is not, then definitely that's not a duty you're going to delegate. All right. If you are going to be feeding the patient to evaluate, that is something that you, the RN, needs to do. All right. So the answer is place the patient NPO. There's a risk for aspiration, so you need to rule that out before you give any oral intake. All right. After the patient is stable, LPN can feed. Definitely. All right. So a client with head injury shows clear drainage from the nose. What's the best, the nurse's best nurse's action? Suction the nasal passage. Test the drainage for glucose. Apply nasal packing or insert a NG tube. So you have a patient that comes in and the patient just met in an accident and you notice that they're having, some little fluid running from the nose. And you're there, you're concerned. What are you concerned about and what would you do at that time? Test the nasal for glucose. Test for glucose. Okay. Why are we testing it for glucose? The patient not diabetic. Why are we testing the patient for glucose? Why are we testing for glucose? Spinal injury. NCLEX spinal fluid. NCLEX spinal fluid. Why are we... So we're checking it for the glucose because of the spinal injury. Okay. NCLEX question. Yes, it's an NCLEX question. Do we have anybody else with another answer? Book World. I guess you were. Oh, everybody wants to sleep? Oh, Lord. So you're checking for CSF, all right? Yes, so the spinal injury, checking for the CSF to see if it is CSF fluid, all right? Because the CSF is what? It's going to be positive for glucose, all right? So if you check it and it's negative, then it's not any CSF fluid there you're thinking of, all right? Cerebrospinal fluid. So there is no leak. So if it's negative, then you're not thinking about that leak, the CSF leak, all right? So you go ahead and always check for glucose. Would you go ahead and apply nasal packing? Would you go ahead and pack the nasal, airway there? And would you insert an NG tube? All right, so let's do this. So the patient comes in and then the patient starts vomiting and the doctor says, let's go ahead and put an NG tube in. But you realize that the patient has the CSF, all right? You realize that the patient has the leak. The patient has the leak and the doctor says, let's go ahead and put in that NG tube. Would you go ahead and put in the NG tube because the doctor says to put it in? No, okay. We have another answer. All right then. So if it's no, why you gonna put it in? What are we concerned about with this trauma patient? And it's another NCLEX question as well. So what about the basal skull fracture? You remember the basal skull fracture? So that is one thing you'll be concerned about. Brain injury, okay. So you'll definitely be concerned about the basal skull fracture. So you don't want to go ahead and insert an NG tube there with that patient with all of those, with the trauma going on and the fluid draining from the nose there. All right. So if you realize that let the doctor know that, oh no, let's get the CT scan first, and then from there, if there's no trauma to the skull, then you can always go ahead and insert your NG tube. All right. Suction the nasal passage. As I say, all of these things you'd want to make sure that you get your CT scan done. All right. So you'd have already activated trauma and get your trauma series done, your CT scan. And then from there, you can go ahead and decide whether or not the patient really, if the patient needs the NG tube, that is. The nasal packing, the suctioning, and all of those things. All right. If you're going to suction, just try not to be passing like anywhere here. Because especially if the patient has any fracture to the nasal bone here, you don't want to go ahead and be using that yank and push all the way down and, you know, causing more problems to the person them nose, you know. So definitely be careful. Just suction at the little opening here and then from there. But always wait for your CT scan to confirm about your basal skull fracture. Then from there you go on. All right. A client with DKA is being treated with IV insulin. We did a question like this earlier. Which lab should the nurse monitor closely? Is it the sodium, the potassium, the hemoglobin, or the calcium? So you have a patient that is in DKA and you're going to be administering insulin. Which lab value should the nurse consider monitoring closely? Is it the sodium, the potassium, the hemoglobin, or the calcium? The potassium, definitely, because the potassium, does the potassium move in or out of the cell? What are we concerned about with the potassium? Is it going to be high or low? Because remember, when you give the insulin, it's going to act like what do you call it now? It's going to act like a transporter, not only for the glucose, but it's also going to be transporting what? It's going to transport your potassium in or out of the cell. So if you have a patient that is in DKA, diabetic ketoacidosis, patient is being treated with IV insulin, which lab should the nurse monitor closely? Is it the potassium, the sodium, the hemoglobin, or the calcium? You're good, Mona. Which of them are you concerned about with a patient that is in DKA and you're giving insulin? Is it the sodium, the potassium, hemoglobin, or the calcium? All right. So the potassium, yes. So the potassium is going to be shifting in or out of the cell. Are you expecting the potassium to be low when you start, you know, giving your insulin, or is it going to be high? So it's going to be shifting into the cells. So you're going to have the patient being at risk for hypokalemia. Yes, it's going to be low. All right, so you definitely want to go ahead and observe, monitor, replace before you start your potassium replacement, because you're expecting it to be like shifting into and then lowering the potassium. So best practice is always to go ahead and do your hourly. I know a lot of times we might just do the finger stick. Some facilities, depending on where you go, it's recommended that you do your iStat. So you can always see your potassium. So that way, even though you have the patients on, you know, the IV drip, the insulin drip, at least you're able to still see the potassium level, the glucose, you know, those Chem8. Yeah, so at least you'll get those little numbers every hour. You get the values every hour so you can know whether or not you need to be adding potassium as you're going, especially if the patient is on it for, you know, a couple days. You're titrating. Definitely you need to be replacing making sure that your potassium is staying up there, because you don't want it to be a case where you start out and the potassium was at 3 and then by the end of the day the potassium is at 2. You need to be constantly monitoring, you know, getting those hourly I-stat with your sodium, your potassium, your chloride, you know, and your glucose, to make sure you're not and then your anion gap as well. So that way you make sure you're not, you know, replacing and losing too much, all right, and risking the hypokalemia or any arrhythmia that comes with it, all right. Yes, so diet is definitely something you want to address as well. But would you be feeding them at that time though, if they're already hyperkalemic, or would you be waiting for a little bit to kind of get that glucose down and then from there? Yes, definitely. So diet is something that you're still gonna be, you know, but you're gonna kind of get their glucose down, because feeding them while you're giving them the insulin is like it's defeating the purpose. You know, you're feeding somebody and then the glucose is just still shooting up, you know. So definitely push your IV fluids, your insulin, your potassium replacement, and all of those things. Check for the diuretic. The diuretic for, if the patient is overload, then definitely you want to do your strict intake and output for this patient, because you'll be loading up on but why the loop diuretic though? For the DKA patient, why the loop diuretic? If they're not, when you're assessing, you know, you want to make sure that you're not giving too much fluid to start causing crackles and all. If you notice that, then you're gonna have to kind of cut down on your fluids, or you don't want to cut down on your fluids because it's DKA, it's life-threatening. So you want to make sure that they're getting all of that fluid to help with the ketones, flushing out all of those ketones. So definitely, you know, they might start having crackles, and then you might start giving the diuretic, despite, you know, just to make sure you're not drowning the patient, you're pulling that fluid, but at the same time you want to get rid of those ketones. And in order to get rid of the ketones, you have to do your high dose of fluids. All right, but I don't think for the initial, like, you know, I don't think for the initial management of DKA, the loop diuretic or diuretics are a part of it. I think it's more if this patient starts developing any complications from the excessive amount of fluids, then it's a part of it. I think if you're giving them too much fluids, then eventually, you know, you're running the risk off. So if that's the case, then you will start giving your diuretics to help with getting rid of that fluid. But I don't remember the DKA protocol having, you know, the diuretics as a part of the initial management. So unless they have like, you know, the underlying heart problem, you're thinking that, yes, this patient is in fluid overload, then okay. Then definitely you want to go ahead and do that. All right. Well, let's do two more, and then that's it. All right. A postpartum client has a boggy uterus with heavy bleeding. What is the first action? So you have a patient. It's more intervention. Okay. So you have a postpartum client who has a boggy uterus with heavy bleeding. What is the nurse's action? Is it call the provider, massage the fundus, start IV fluids, or administer antibiotics? So you have this patient who just had their baby, and you realize that the patient is having heavy bleeding, but the uterus is also boggy. What is the first nursing action for you? Are you going to be running to call the provider? Are you going to be massaging the fundus? Are you going to be starting IV fluids or administer antibiotics? Massage. Definitely. You want to go ahead and massage the fundus. Why are we massaging the fundus though? Cause we just want to feel up mama tummy. Huh? Are we just rubbing it because we're like, why are we doing that? Why are we massaging the fundus? What are we thinking about? So you have this patient who just had, had her baby. Retraction. Okay, so we're trying to get retraction of that uterus. Fine. Okay. But what are we concerned about? You just had your baby and you're having heavy bleeding and your uterus is very boggy. It should be hard to prevent bleeding. Yes, because now this patient is at risk for hypovolemic shock, hemorrhage. All right, postpartum hemorrhage is what you're concerned about. So you want to make sure that you massage as best as possible to get that, uterus firm, to cause a contraction to help with stopping that bleeding, because the patient is going to constantly be bleeding and then, eventually will bleed out and you don't want that. So go ahead and start your massage to help with that. All right, calling the provider is another one that you'll definitely want to do, but you want to go ahead and spend time doing that. You can probably holler at somebody else and say, hey, let Dr. X know that, this patient is bleeding, especially if the patient is going into shock. You realize that the blood pressure is getting low, the patient is very tachycardic. Definitely you want to, get that massage going. Starting the IV fluids, is that priority? If you were supposed to choose between the two of them, would that be priority at that time? You definitely want to do your fluids, but at the same time, you want to focus on your massage. All right, so you want to do your fluids to help with the bleeding. All right, but it doesn't make sense you hang the fluid and the patient is there just bleeding out. It's you're defeating the purpose. You understand? You want to make sure that uterus is actually closing up, contracting. So you continue with massaging to help with getting it smaller, get it from being boggy to being firm, and you give that fluid. So hopefully that will help with slowing down the bleeding. All right. Administer antibiotics. Would you administer antibiotics to this patient though? Would you be administering antibiotics to this patient? No. Yeah, I wouldn't be administering antibiotics to this patient unless, I don't even know why. But I wouldn't be administering any antibiotics to this patient at this time. All right. But the fundal massage is the first step when you're managing postpartum hemorrhage. All right. Yeah. A 2-year-old with dehydration from gastroenteritis has sunken eyes and is very lethargic. So 2-year-old is dehydrated from gastroenteritis. So the mother comes in and they say the baby not taking anything. The baby just looks so weak. The eyes are sunken. Patient just looks lethargic. Which is priority for you? Are you going to be offering oral rehydration solution to this patient? Are you going to start an IV with the fluids? Encourage rest or provide clear soda to this patient? What are you going to be doing for her? Not necessarily. Okay, which one? So you have this 2-year-old and okay, so you're going to start the IV. Okay. But why you couldn't just, the child is there, why you couldn't just give the mother, some oral rehydration salt and say, Mommy, just feed the baby with this? Or, why you want to do that? Why you want to go ahead and, torture the baby? It's 2-year-old. Why you want to torture the baby? All right, so yeah, definitely you'll start the IV, especially with the child having the sunken eyes. It's not like today this start. You understand? This probably started a few hours like yesterday leading up. You understand? Most of the time you're looking at like the dry eyes, the mucous membrane. Then you probably can say, okay, we can start some IV fluid. But if you realize that their eyes are sunken, then definitely, you're at severe dehydration taking place there. So you definitely want to go ahead and start with your IV fluids and get that in. The oral rehydration salt, you'd give that if the child is in the early phase. the mother comes in and says, oh, the child hasn't been eating, but you can see that the child is still crying, making tears, you can always go ahead and give that. But if you realize that you're there poking the child and the child not even doing anything, the child just lying there, and you have a 16, you have a 18, whatever size you want to decide to, you know, do your IV with for your pediatric, and you're there poking the child and the child not doing anything, you know, the child don't have 1 ounce of energy, the patient, you know, pass out everything, then definitely you want to go ahead with your IV. So your sunken eyes, the lethargy, the weak cry, or some no tears, those are things that are leading up to, well, not the no tears is like, you know, in the moderate, but the sunken eyes, the lethargy, they're not crying, or even if they're crying, it's more like, they don't have the energy. Definitely you want to kind of jump on to getting your IVs and start pushing your fluids, all right, for that baby. The oral rehydration salt, as I say, you know, you give that if they are at a point where you'd say they're like stable, they're stable. So they're probably walking around, you see them with the bottle at the head, doing 1 and 2 little tricks, but they're not really swallowing anything, and even so they probably vomit it up. Definitely you will try the oral rehydration salt because you don't want to torture them. You understand? Encouraging rest during this time is not, you know, them already are rest because them lethargic. You understand? So you won't encourage rest at this time. Providing clear soda is still a no-no. All right. So the most important thing is go ahead with your IV because this patient is severely dehydrated. And then, you know, with children, you know, they decompensate so fast. So you have to actually get things going real quick for these patients. All right. A client on hemodialysis, yes, you have to act real fast for these patients. All right, you can't be there playing around and say, yes, they're going to come around. No, they're not going to come around. Before you know it, them kick the bucket. You understand? So definitely get your things going and just get your fluids, start pushing. You know, you push your fluids. This patient, you're not going to hang that IV bag up there and waiting for it to run in. No, you're going to get your syringe and be pushing until you're getting, you know, if probably you see the child start moving a little bit more because now they feel that the IV is in the arm and it's cold and things like that. You start seeing a little bit of a change in them. Or if you had them on the monitor, you'll realize that probably their heart rate is going down a little because their body is responding to the fluid. All right, so definitely you have to act fast with these patients because, as I say, time is very, very important for the patient. Yes, they start come around a little bit more. All right. A client on hemodialysis reports dizziness and lightheadedness post-treatment. Which is priority? So you have a patient that is, you know, a renal patient that goes in, they had their dialysis and they come home and they say, oh, they're just feeling dizzy, they're just feeling lightheaded. What is the priority for that patient? Is it to place the client in a flat position, restricting? I just doing the last one. I'm doing the last one. This is the last one. A client on hemodialysis reports dizziness and lightheadedness post-treatment. Which is priority? Place the client flat, restricting the fluids, offer a snack, or reassure the client. All right, so this patient just had the dialysis done. All right, and the patient comes and says, I'm feeling so dizzy. I'm feeling lightheaded. What are you going to be doing? All right, what is priority for you? For this patient? Is it to place the client in a flat position? Is it to restrict fluids? Is it to offer snack or reassure the client? Just one answer? Just one. A, B, C, or D? Going once. Going twice. Flat position. Restrict fluids. Make him eat. Okay. Why are they restricting fluids now, Mona? Hydrate. Okay. But remember, you just pull off, you just take 2 liters of fluid from the man, you know. You just pull off 2 liters of fluid from the gentleman. So aren't you expecting that he's going to be like dizzy and lightheaded? You just take 2 liters out of 6 liters. You understand? You have the poor gentleman sitting up for the entire day. And then now you take 2 liters from him during dialysis. I'm going to feel weak and tired, you know, I'm going to feel dizzy. So all I need to do is reposition him, and then that will help with it. Don't have it, you know, then definitely, you know, once you reposition him, that usually will help. Nothing is wrong with feeding and all, but right there, what is going to be priority is trying to correct that. So you put him in that position, let him lie down, and then you're going to have that venous, you know, flow to the brain. Same brain just need a little bit of a, you know, blood flow. It needs some blood flow to the head. All right, the brain to help with that. So that way he's not getting dizzy or lightheaded. And sometimes they become so hypotensive as well. All right, so you put them in that flat position. It helps with their blood pressure. It also helps with their dizziness, you know. So you start off with that, because you're going to give him the food to eat, and him still sitting up there eating and dizzy. Him still lightheaded. You understand? So just let him lie down for a few minutes, and then from there, you know, some persons, it take a few hours for them to actually get out of that state. So just let them lie down for a few minutes, and then from there they can always go and eat. But a lot of them, they're not really interested in eating, because they're just feeling so tired at that time. They're just feeling exhausted, because just imagine you're sitting up, or you're in a 30 degrees, you know, position, and you're getting your dialysis for the entire day. You spend 4 hours. How many hours you're up doing dialysis? And they take 2 liters, 3 liters. Your blood pressure is going to be low. You're just going to feel so drained. You know, you just want to lie down. And once you lie down and the blood flow to the brain is going to correct the dizziness, you know, the lightheadedness, the blood pressure is going to improve. And then from there, the procedure is rough. Yeah, man, it's rough for them. You understand? It's very hard for them. So definitely let them, you know, reposition them, because of all of that is because of the blood pressure just being too low. All right, so definitely you want to do that. All right, and then from there you can always go ahead and offer them a snack. You know, they'll probably eat it. And you can also, but you want to restrict fluids from them though. You want to restrict fluids from them. Well, they will be on our, you know, the restriction will be there, but you'd still want to give them their fluids during that time to drink. All right. Depends on the patient, book world or real world. No, Mona, remember we're doing the real world. Remember that the students are going to be doing the exam in the real world, you know. All right, the real world they're doing. We're not doing anything based on our experience as a nurse right about now. Being from Jamaica, because all of them patients know that did. If you choose the answers that, you know, in our real world that we're practicing, the patients are gonna, you know, because we don't have some of the resources. So we're not really thinking like, you know, the real world like that. Where resources are readily available, you're not short-staffed and, you know, stuff like that. So you have to think about the NCLEX real world. Yes, yeah, man. If we are supposed to follow what we're doing to save patients and coming to do these exams, yeah, man. I tell you, when I was doing my exam, I had to sit down, and every question I'm doing, I'm like, if there's no short staff, there's always resources available, and it's the perfect world. When I tell you, I had to repeat that every single time I was going at a question, just because I didn't want it to be a case where I'm thinking about that. Oh, you know, it's a floor that has only 2 nurses and 30 patients, and me have 15 patients, plus me I charge the floor, plus I'm doing all of those dressings, medication, transport patient. Like, no, if I was supposed to be answering the question based on my experience, all the patients them, you understand, all the patients that I have would have either something would have wrong with them. You understand? So I had to kind of reprogram my mind and be saying, okay, then this question is asking this. This is a one to one, you know, in terms of patient ratio. Only 1 patient, 1 nurse, and that's it. There's no patient that is dying beside me that me have to go think about running to. Nothing like that. That's how I had to reprogram my mind to go and see this NCLEX. So, you know, you have to think of it, the real world, the NCLEX world, and then from there you answer your question. All right, but anyways, it was really nice. You know, it was really nice hanging out with you guys tonight. All right. On YT, thank you, thank you, thank you. And on TT, thank you, thank you, thank you for tuning in. Yeah, let's join again next week, Thursday, from 7 o'clock again. Yeah, next week, Thursday at 7 o'clock. I was thinking about on Tuesday, but, you know, I'll be on the live on Tuesday. We can always chit-chat, and then from there, we'll see if we'll do NCLEX questions. Or we can probably do, like, you know, 30 minutes of NCLEX question, and then we can chat a little bit more on Tuesday. All right, so we'll see how the turnout is, and then from there. But thank you for tuning in, and all the wonderful students that are planning on sitting their exams. You know, I don't know when you guys are doing your exam, but I'll be here. Teacher, you're welcome, student. You're welcome, Mona. Not a problem, but I'll try to see if I can dedicate, you know, Thursdays to doing the NCLEX, and then from there. Money gone. Now I see it. Thank you for doing that. How did we do? You guys did well, you know. You guys did well. I know that 6602 after I don't know what time is our bedtime, but I'm gonna tell you. After probably like the last hour or so, yeah man, I pay wrong man share do. Mona, I think you were busy as well. Yes, you passed. Yes, you were doing good. You were doing good with your answers. But overall, I think you guys were doing good. Yeah, you were doing good. What's our grade? You trust our judgment? Yeah, man, I trust in the judgment. Except, you know, at the time, where is Mademoiselle? You need to go to her nurse. Yeah. Oh, you're not a nurse? You're not a nursing student? Except the one that, you know, with the potassium. The one with the potassium, that one was a little bit, you know, frightening. Maybe go on a little bit. Maybe did I try? Oh, you're good. You're good. Would you hire me? Yeah, I would hire you. I would hire you guys. Yeah, it was really good though. It was really good. Yeah, and I remember that a lot of persons on here were students as well. So, you know, they're not thinking along the line that, okay then. So, this is what the class is for, or the session is for. You know, for us to kind of come and spill the answers that we're thinking and try to hear different persons sharing why it might not be this answer or why it's that answer. So it's a learning experience for me as well for some of the questions them. So definitely, you know, we all pass, and that's the most important thing. Speak it into being. You're in States. Yes, I am in Texas right now. So remember to go ahead and make sure to follow me. And remember to go over to YT, ThinkNursing, my YouTube page, and follow me over there. So just in case, you know, we did some other sessions the other day where we were doing the same questions. You can always go over there and watch the live. Play it while you're driving and just listen to the questions and the answer. And if you're an international nurse as well, there are a lot of tons of information over there that, you know, persons from TT here, TikTok was asking that we were answering on the live. So definitely go over there and follow, and you know, you can always ask me any questions, inbox me, text me, whatever it is that you prefer, and I will answer them. All right. Sometimes I tend to read into the questions too much. You have to try and just think about, you know, but you're already a nurse, but you just have to try and think of as I say, you just have to think of the situation as is. Don't add anything else to it. We were only doing it because I'm trying to have us study a little bit more than what the question is. You understand? Think outside of the box as to why those are not the best answer. Let's just try to rationalize it. So that's the only thing. But for the exam, you definitely have to just read the question. Whatever is there, that's it. That's the patient. There's nothing more to the patient than what is on the paper or on the computer. All right. You're welcome. Not a problem. Not a problem. So that's just about it. And then from there, because I just feel as though if you're going to do a review course, it doesn't make sense to go and just sit down and listen, or you focus on just the review course. You understand? Study to the point where each A, B, C, D, you have an understanding as to what is going on there and why that couldn't have been the answer. Because A, B, C, D, one of those answers might be another question on the exam. And you might just, you know, not have studied widely enough to answer that question. But based on the fact that you've done one test question and kind of, you know, examine it a little bit different while you're answering that specific question, you might just have learn something that will help you in that question. So the review course, I feel as though is more, if you go and swat this thing, if you just sit down and just say, oh, the answer is A, and you move on and you don't understand the rationale with it, or you don't look at the other options, you might just go in the exam being so narrow-minded that even if the answer is there and they put it a different way, you're not going to be able to answer it correctly because you never really see it on the paper, or you never see it or hear it in the review course. And then not only that, you're not thinking about just the exam. You want it to be a case where whenever you're done with your NCLEX and they put you in the working world, the doctor might come and say, oh, why are we doing this? You don't have to be thinking about, oh, what did they say in the review course? No, you want to seem like you're smart. You know you're smart, but you want to have additional information to share that, oh, this is why we're doing it. And it's not because one person choose, you know, if there is an answer that has probably like 5 different rationales to it as to, you know, answering the question, you don't want it to be a case where that person just choose the easiest answer and put it in a review course and say, oh, this is the answer for it. And in your mind, you're just thinking that that's the only answer to it. When really and truly, there are probably 5 other reasons why. But because they're consolidating, you know, or making that course a little bit more concise, easy to get through to the exam, you might just see the one answer and just think that that's the only answer there is on earth with that question. But there are different ways of interpreting or different answers to the same one question. So basically, that's just it. I'm looking in on assessment level 2. Yes. And thank God you're not dry glory. Huh? Even by not dry glory. There will be a surprise gift if you find me. Ella, welcome. Follow the, yeah, but if you understand, so this is just to kind of, you know, open up the question a little bit. I will try to just answer it as best as possible, and then from there, just think of it as a pathophysiology class in the making as well. All right, but yeah. Oh, okay, like boring. No, me can't deal with the boring people there. Me can't deal with the boring class. No, you must have a little, you know, a little vibe, a little energy to go with it. Because if not, you know, you're not going to remember anything. You're not going to remember anything that much. All right, so that's all. All right, well, you know, it's 11 o'clock. I'm going to watch a movie. Yeah, I'm going to watch a movie and then go sleep. So enjoy your evening. Not a problem, not a problem. All right, see you guys next week. And during the week, during the day, I try to, yes, during the week, I'm going to try my best to go ahead and post, you know, on the calendar. I'm new to social media in a sense, so just bear with me. 22:10 a.m. for you. Okay, yeah. So during the week, you might hear as well. All right, no problem. You too. It's 11:11 for me, p.m. That is. But I'm not really like say sleepy. Yes, I will definitely do it a little bit more often. I don't think like, you know, I'll do from 7 to 11. Like I say on Thursdays, I'm going to try to do a marathon just because I'm not working on Friday. So I will stay up a little bit longer and do the questions, you know. So whoever wants to join. But usually I'll try for the 1 hour. But most of the time we're still going to chat for probably like 2 hours, 3 hours either way. So definitely I think I'm going to be doing Tuesdays and Thursdays for the NCLEX questions. And then I'll still do my 7 o'clock live where I just sit down and talk. So just in case anybody have any questions, they can always ask. Yeah. All right, so, but thank you so much for tuning in. If we don't stop, I'm not going to stop. So enjoy your morning or your night, all right? And thank you so much. Remember to tap up the live and follow me. All right, most importantly, follow me. All right, bye. All right, good night.